శతాబ్దాల సేవా చరిత్ర కలిగిన ఒక ఆసుపత్రి, లక్షల మంది పేదలకు ఆశగా నిలిచిన ఒక ఆలయం. అది గుంటూరు ప్రభుత్వ ఆసుపత్రి.
నేను గుంటూరు ప్రభుత్వ ఆసుపత్రి సూపరింటెండెంట్గా పదవి బాధ్యతలు స్వీకరించిన తర్వాత ముందుగా ఆసుపత్రి పరిస్థితులన్నీ కూడా గమనించాను. ముఖ్యంగా ఎమర్జెన్సీ డిపార్ట్మెంటు, అలాగే ఇక్కడ ఉన్న ఇన్ఫ్రాస్ట్రక్చరు, ఎక్విప్మెంట్, అలాగే హైజీను, శానిటేషను, అలాగే స్టాఫ్, డాక్టర్స్ అవసరాలు.
ఎంతో మంది ప్రాణాలను కాపాడిన ఈ గోడల మధ్య డాక్టర్లు, నర్సులు, స్టాఫ్ సేవని తమ ధర్మంగా చేసుకున్నారు. కాలం మారింది, వైద్యం మారింది. అదేవిధంగా గుంటూరు ప్రభుత్వాసుపత్రి కూడా మారుతోంది. ఒకప్పుడు మౌలిక వసతుల కొరతతో ఇబ్బందులు పడిన ఆసుపత్రి ఈరోజు ఆధునిక వైద్యానికి ప్రతీకగా నిలుస్తోంది. ఈ మార్పు వెనుక ఉన్నది స్పష్టమైన నాయకత్వం, అలుపెరగని కృషి మరియు ప్రజల పట్ల ఉన్న నిజమైన బాధ్యత.
మార్పు అనేది పేపర్ల మీద ఉండటం కాదు, అది గ్రౌండ్ లెవెల్లో ఒక రియాలిటీగా మనకు కనిపించాలి అనే ఉద్దేశంతో సాహో అనే ఒక ఇనిషియేటివ్ కాన్సెప్ట్ తీసుకొని ముందుకెళ్ళాను.
పదవిలో కూర్చుని ఆదేశాలు ఇచ్చే నాయకత్వం కాదిది. క్షేత్రస్థాయిలో నిలబడి సమస్యలను చూస్తూ పరిష్కారాన్ని సృష్టించే నాయకత్వం. ఆయనకు గణాంకాల కంటే గ్రౌండ్ రియాలిటీ ముఖ్యం. అందుకే కొన్ని సందర్భాల్లో గుర్తింపు లేకుండా ఒక సాధారణ వ్యక్తిలా ఆసుపత్రిలోకి వచ్చి వార్డులు, ఎమర్జెన్సీ, ఓపీలు, సిబ్బంది స్పందన, పేషెంట్ల అనుభవం అన్నిటినీ స్వయంగా గమనించారు.
మొదటగా ఎమర్జెన్సీ డిపార్ట్మెంట్ పనితీరు మెరుగుపరిచాము. అక్కడ త్వరితగతిన స్పందన, అలాగే రిఫరల్ సిస్టము మెరుగుపరిచాము. అక్కడ క్రిటికల్ కేర్ ఐసీయూ బెడ్స్ పెంచాము. ఆపరేషన్ థియేటరు, ల్యాబుల్లో ఎక్విప్మెంట్ కొత్తవి తీసుకొచ్చాము.
కొత్త ఐసీయూలు, ఆధునిక ఆపరేషన్ థియేటర్లు, డిజిటల్ డయాగ్నోస్టిక్ ల్యాబ్స్, శుభ్రతకు ప్రాధాన్యత ఇచ్చిన వార్డులు. ఈ మార్పులు ప్రతి పేషెంట్కు గౌరవాన్ని, ప్రతి వైద్యానికి నమ్మకాన్ని అందిస్తున్నాయి. ఒక సంవత్సరంలో సాధ్యమా అనిపించిన మార్పు ఇక్కడ వాస్తవమైంది. కేవలం మాటల్లో కాదు, భవనాల్లో, సౌకర్యాల్లో, సేవలు, మానవీయతలు. గత ఒకే ఏడాదిలో 150 కోట్లకు పైగా అభివృద్ధి పనులు గుంటూరు ప్రభుత్వాసుపత్రిని ఒక కొత్త స్థాయికి తీసుకువెళ్లాయి.
మొదటగా ఇన్ఫెక్షన్ కంట్రోలు, శుభ్రత మీద ప్రత్యేకమైన దృష్టి పెట్టి ఫోకస్డ్ గా పనిచేశాము. అలాగే పేషెంట్ సేఫ్టీ ముఖ్యము, పేషెంట్ ఫస్ట్ అనే కాన్సెప్ట్ తోటి ముందుకెళ్ళాము. ఏ ఆసుపత్రికైనా భవనాలు కాదు బలం, అక్కడ పనిచేసే మనుషులే అని నమ్మి ముందుకెళ్ళాము.
నాట్కో క్యాన్సర్ సెంటర్ 100 పడకల ప్రత్యేక బ్లాక్, అత్యాధునిక పెట్ సిటీ స్కాన్ యంత్రం ప్రపంచ స్థాయి నిర్ధారణను ఇప్పుడిక్కడే అందిస్తోంది. తల్లి బిడ్డల కోసం మాతా శిశు ఆరోగ్యానికి అంకితమైన మదర్ అండ్ చైల్డ్ హాస్పిటల్ వందలాది ప్రాణాలకు భద్రతగా మారుతోంది. ఆర్థో ట్రామా విభాగాల్లో 80 పడకల ప్రత్యేక బ్లాక్, నూతన ఆపరేషన్ థియేటర్లు, ఐసీయూ, హెచ్డియూ, ట్రామా కేర్, ప్రతి సెకను ప్రాణాన్ని కాపాడే సన్నాహాలు. ఎమర్జెన్సీ మెడిసిన్ విభాగం ఇప్పుడు మరింత వేగంగా, మరింత సమర్థంగా 15 పడకల ఐసీయూ నుంచి 25 పడకల అడ్వాన్స్డ్ ఐసీయూ వరకు అత్యవసర సేవలకు పూర్తి సిద్ధత. డయాగ్నోస్టిక్స్ లో విప్లవం. డిజిటలైజ్డ్ ల్యాబ్స్, ఎక్స్రే, ఈసీజీ, ఆడియోమెట్రీ, ఈఎన్టీ, ఆప్థాల్మాలజీ, గ్లకోమా క్లినిక్. ప్రతి పరీక్షకు స్పష్టత, నమ్మకం. రక్త బ్యాంకులు గత ఏడాదిలోనే 50కి పైగా రక్తదాన శిబిరాలు, 3000 యూనిట్లకు పైగా రక్త సేకరణ. ప్రాణాల కోసం నిలిచిన వ్యవస్థ. సీనియర్ సిటిజన్ల కోసం ప్రత్యేక జెరియాట్రిక్ వార్డ్, హిమోఫీలియా, థలసీమియా రోగుల కోసం ప్రత్యేక బ్లాక్. ఆసుపత్రి చుట్టూ కొత్త రోడ్లు, కాంపౌండ్ వాల్స్, క్లోజ్డ్ డ్రైనేజ్. హరితాభివృద్ధి, స్వచ్ఛతే ఆరోగ్యం అనే ఆలోచనకు ప్రతీక. ఇవన్నీ కలిపితే కేవలం అభివృద్ధి కాదు, ఇది ఒక వ్యవస్థలో వచ్చిన మార్పు. ఈ మార్పు వెనుక ఉన్నది నాయకత్వ దూరదృష్టి, డాక్టర్ల నిబద్ధత, నర్సులు, సిబ్బంది సేవాస్ఫూర్తి మరియు ప్రజల ఆరోగ్యంపై ఉన్న నిజమైన బాధ్యత.
ఇక్కడ పనిచేసే డాక్టర్లు, నర్సెస్, పారామెడికల్ సిబ్బంది, శానిటరీ అండ్ సెక్యూరిటీ సిబ్బంది ఒక టీమ్ గా పనిచేస్తూ వారి మధ్యలో కమ్యూనికేషన్, కోఆర్డినేషన్ బాగా ఉండేలా ఇంప్రూవ్ చేసి మంచి రిజల్ట్ సాధించాం.
నమస్కారం అండి, నా పేరు ప్రవీణ్ కుమార్. నేను హాస్పిటల్ అడ్మినిస్ట్రేటర్గా ఈ హాస్పిటల్లో పనిచేస్తున్నాను. ప్రభుత్వ సమగ్ర వైద్యశాల గుంటూరు అనేది దేశంలోనే ప్రఖ్యాతగాంచిన టీచింగ్ ఇన్స్టిట్యూట్. ఇక్కడి నుంచి ఎంతోమంది గొప్ప గొప్ప డాక్టర్లంతా కూడాను ప్రపంచానికి అందించిన ఘన చరిత్ర ఈ హాస్పిటల్ది.
అందరికీ నమస్కారం. నేను డాక్టర్ బి వెంకటేశ్వరరావు, సివిల్ సర్జన్ అడ్మినిస్ట్రేటర్. గడిచిన 1 ఇయర్లో ఆసుపత్రుల్లో వివిధ రకమైనటువంటి కార్యక్రమాలు చాలా వినూత్నంగా డాక్టర్ ఎస్ఎస్వి రమణ గారి ఆధ్వర్యంలో చేపట్టడం జరిగింది. ప్రత్యేకంగా పేషెంట్లు సౌకర్యార్థం మనము 18 ఓపీ కౌంటర్లను ఎక్స్టెండ్ చేయడం జరిగింది. అందుట్లో ప్రతి ఒక్కరికి కూడా ఇమీడియట్లీ ఓపీ టికెట్ని తీసుకునే విధంగా, అలాగే డిఫరెంట్లీ ఏబుల్డ్ పర్సన్స్కి కూడా ఒక ప్రత్యేకమైనటువంటి కౌంటర్ని ఏర్పాటు చేయటం, ఆరోగ్యశ్రీ కౌంటర్ని ఏర్పాటు చేయటం, అట్లాగే స్త్రీలకు ప్రత్యేకమైనటువంటి కౌంటర్స్ ఏర్పాటు చేయటం కూడా జరిగింది.
అందరికీ నమస్కారం అండి. నా పేరు డాక్టర్ చంద్రకుమార్. నేను ప్రొఫెసర్ ఆఫ్ జనరల్ సర్జరీ, గవర్నమెంట్ జనరల్ హాస్పిటల్లో. మన ఎస్ఎస్వి రమణ గారు సూపరింటెండెంట్గా వచ్చిన తర్వాత ప్రజాసేవ, మన పేషెంట్కి వైద్య సేవ అందించటం ఒక్కటే మాకు ఇదివరకు అలవాటు ఉండేది. ఆ వైద్య సేవ కరెక్ట్గా అందుతుందా లేదా, అడ్మినిస్ట్రేటివ్ ఆస్పెక్ట్స్ ఇవన్నీ కూడా చూడటంలో ఆయన నుంచి నేను చాలా నేర్చుకున్నాను.
నమస్కారం అండి, నా పేరు ఎన్ శ్యామ్ కుమార్, ప్రొఫెసర్ ఆఫ్ ఎనస్థీషియా, వర్కింగ్ యాజ్ డిప్యూటీ సూపరింటెండెంట్ ఇన్ గవర్నమెంట్ జనరల్ హాస్పిటల్ గుంటూరు. హాస్పిటల్ అభివృద్ధిలో మన ఎస్ఎస్వి రమణ సార్ సూపరింటెండెంట్గా వచ్చిన దగ్గర నుంచి హాస్పిటల్ అభివృద్ధి శరవేగంతో ముందుకు తీసుకుపోతుంది. అంతకుముందు తీసుకున్న ప్రోగ్రామ్ అన్ని చకచక జరుగుతూ ఉన్నాయి. చాలా ఎపిడమిక్స్ ఇచ్చినా కూడా చాలా వాటి అన్నింటినీ చాలా చాకచక్యంగా చాలా దీంతో ట్యాకిల్ చేసి పేషెంట్ల కేర్ కానీ అంతా చాలా బాగా జరుగుతుంది.
అందరికీ నమస్కారం అండి. నా పేరు డాక్టర్ ఎన్ ఉమాజ్యోతి, ప్రొఫెసర్ అండ్ హెచ్ఓడి, డిపార్ట్మెంట్ ఆఫ్ సైకాట్రీ, గవర్నమెంట్ జనరల్ హాస్పిటల్ గుంటూరు. నేను డిప్యూటీ సూపరింటెండెంట్గా కూడా వర్క్ చేస్తున్నాను. ఎస్ఎస్వి రమణ సార్ సూపరింటెండెంట్గా వచ్చాక మా హాస్పిటల్లో చాలా మార్పులు జరిగినాయి. గ్రీనరీ చాలా బాగా ఇంప్రూవ్ అయింది, ఆహ్లాదంగా ఉంది చూడటానికి హాస్పిటల్ ప్రెమిసెస్ అంతా.
అందరికీ నమస్కారం అండి. నా పేరు డాక్టర్ డిఎస్ఎస్ శ్రీనివాస్ ప్రసాద్. నేను గుంటూరు మెడికల్ కాలేజ్ అలాగే ప్రభుత్వ సమగ్ర ఆసుపత్రి గుంటూరు డివిఎల్ డిపార్ట్మెంట్ ప్రొఫెసర్ అండ్ హెచ్ఓడిగా పనిచేస్తున్నాను. మన సూపరింటెండెంట్ గారు ఎస్ఎస్వి రమణ గారు చాలా అభివృద్ధి కార్యక్రమాలు చేస్తున్నారు. గ్రీనరీ ఇంప్రూవ్ అయింది, క్లీన్ అండ్ గ్రీన్ ప్రోగ్రామ్ బాగా జరుగుతోంది. అలాగే ముఖ్యంగా ఏంటంటే పేషెంట్స్ చాలా సాటిస్ఫై అవుతున్నారని చెప్పి చెప్తున్నారు. ఇది చాలా ఆనందించదగిన విషయం.
ఐఎమ్ డాక్టర్ ఉప్పాల శ్రీనివాస్, ప్రొఫెసర్ ఆఫ్ ఈఎన్టీ డిపార్ట్మెంట్ అండ్ డిప్యూటీ సూపరింటెండెంట్ ఆఫ్ గవర్నమెంట్ జనరల్ హాస్పిటల్ గుంటూరు. రమణ గారు సూపరింటెండెంట్ అయిన తర్వాత చాలా చేంజెస్ వచ్చినాయండి. మెయిన్ ఏంటంటే ఆడియాలజీ అంతకుముందు యాక్చువల్గా లేదు. ఆడియాలజీలో బెరా అనే ఇన్స్ట్రుమెంట్,
Recording in progress.
Are we ready? Hello. Yeah, give us 2 minutes, Andy. Why don't you call her? Padmavati garu, give us 2 minutes. Okay.
Recording stopped. Recording stopped.
To answer. And it's time to introduce our first speaker of the evening, Dr. Padmavati Pagadala. Okay. It's now my pleasure to introduce our first speaker, Dr. Padmavati Pagadala. Dr. Pagadala is highly experienced in OBGYN with over 30 decades of clinical, academic, and teaching experience. She completed her MBBS in Guntur Medical College, and then she did her residency in OBGYN in Washington University, St. Louis, where she's also served as a chief resident and received multiple academic honors. And she also worked as an associate professor with Emory Healthcare. Currently, she's practicing in Georgia as a hospitalist and also private practitioner, and she's continuing her strong commitment to excellence in patient care and medical education. Please join me in warmly welcoming Dr. Padmavati Pagadala. Thank you. You can, yeah, you can start, please.
Okay. Should I put the share on or my slides are showing up?
Yeah, we can see you very well.
Okay. So, andarki namaskaram. Na peru Padma Pagadala. I've actually graduated from Guntur Medical College, 1991 lo. Since then, I've been working in the US. So, it's my pleasure actually to join everybody on this auspicious occasion where we are opening the new maternal center at Guntur Medical College. So I compiled a little, I thought this is a great occasion to talk about how maternal health has evolved over the years to show that everything takes time, and when effort is put in the right direction, then great strides can be made in providing better care to the population. Women actually form 50% of the world's population, and they are the center of a family, and they are actually who are instrumental in bringing in the new generation. So women's health is about taking care of humanity in general. So in the good old days, of course, women were always considered second-class citizens. They did not have as much importance or did not get as much share of the economy. So women's health was also home-based, community-based, more female-centered, and most of the deliveries were attended by midwives, family, neighbors. So there was a lot of emotional support to women when they were before the 18th century. But most of the complications that happened during childbirth were dealt with prayers more than anything. So before the 18th century, you know, it was all home-based, so people just took care of things at home. The mortality was in the range of 1 to 5%. Women, when they were giving birth, it was like having a rebirth because there were a lot of people who did not make it. A few mothers who did not make it. The midwives were very instrumental in attending the births. There were a lot of rituals, amulets, herbal medicine were practiced. A lot of spiritual things were done. Most of the time, people did not have anything that was aseptic. So people used oil hands, massage, clean cloths, birthing stools and chairs were used so that women could squat and have the baby. And slowly there were a few male surgeons who were doing some experimentation with some destructive tools, because when the baby doesn't make it, when there is a long and obstructed birth, then they use destructive tools to extract the baby from the mother. In this process, the mother's life was endangered. The complications were high, and mainly because of infection, a lot of bleeding, severe anemia because nutrition was not very good, obstructed labor, and then women used to get very exhausted, dehydrated, and if they had high blood pressure and pregnancy-induced high blood pressure, they used to have convulsions, have a lot of complications. So in the process also, the baby did not make it because of lack of care. So in the 18th and 19th century, slowly the care started shifting to the hospital. There were more physicians who kind of had a little more idea about normal anatomy, how to do a difficult delivery, and most of the physicians were men. So at this time, slowly there were more medications that were being discovered, a little bit of pain control with chloroform, scopolamine, morphine were used, even though now we kind of are a little more aware of the effects on the baby with morphine, and don't do it as close to the delivery. So there was also use of forceps, maybe some early cesarean attempts for difficult births. So they were still evolving in the 18th and the 19th century. But when things started shifting to the hospital and there were a lot of women, segregated in the hospital, there were also a few challenges that started happening. There was an increase in infection. Actually, there were more deaths in the hospital than if somebody had a baby at home because of the infection. And at this point, there were more involvement of fathers. In the good old days, they used to not allow fathers to get into the whole birthing process, but now there was fathers getting involved. And of course, by this time, there was a little more acceptance with intervention, and those were mainly cesarean section, forceps, doing episiotomies, things like that were happening. But most of these medical centers were available only in highly populated areas like large towns and cities. And there was a lot of barriers were created to access because they could only be in certain locations, and there was also a lot of cost associated with things. So in the meantime, it was discovered that prenatal care, which is more preventive, could decrease the chance of complications. So prenatal care was useful in detecting things a little earlier, like if women developed high blood pressure or diabetes. Slowly, we started having technology getting into the whole thing with ultrasound. There was earlier detection of fetal anomalies. Then genetic testing was useful to test for chromosomal abnormalities when the baby is still in utero. Chronic fetal monitoring, you can now have, before the baby was secondary, the mom was more important, and it was all about saving the mom's life. But slowly, because of electronic fetal monitoring, we started optimizing the baby's health also. Now, there is also technology where you can do surgery on the baby and decrease the effects of certain birth defects, more availability of blood, which is life-saving, and also pain management with births, with epidurals and spinal blocks. and better care of preterm infants. Before, if babies were born premature, they would never make it. But now, if I think they're pushing earlier and earlier, babies not dying of prematurity. So even now it's like around 24 weeks and after they try to save the baby by providing care for the preterm infant. So it's all has happened because of technology, hospitals like this, which are again available in more highly populated areas. The only downside to having this hospital care is there is not as much emotional support. There is a lot of cost associated with this, available in only urban areas or larger towns. And access to the general population is limited because of the limited facilities that are available. So then we come to, what do we do so that there's more care available to more people? The access to care has to be addressed here. This is, especially even not only in India, but many parts of the world, a lot of people do live in the rural areas, 65 to 70% in India. There is limited resources, there is limited accessibility, education is not as good, and difficulty with communication. Those are the Indian demographics. But I think for every problem, there is a solution. If we have to do more outreach, there are many ways nowadays with technology that people are able to provide care through telemedicine, mobile clinics. There are smaller hospitals in smaller towns, training local personnel to do some basic care so that if there is the triage that's done and anybody who is kind of having more problems, they can be then moved to a bigger facility. And this is all possible, of course, with government funding and looking at solutions that are able to access more population. So then we get into like, is home birth always a bad thing and a hospital birth is the best thing? So there are a few numbers that I came across. I thought it would be nice to actually discuss them. So the adverse outcomes with delivery are at least not super high. 95% of people actually do very well without a lot of intervention. But adverse outcomes a little bit more when you do home birth versus a hospital birth. It's 3.7 versus 1.8. But when you are in the hospital, there is a higher chance of intervention. At home, the intervention rate is, say, 3.8%. When you're in the hospital, the chance is 12.8%. And the NICU admissions are a little bit higher when you're in the hospital. It's 2.8% versus 1.1%. So sometimes this can cause, there's a lot of cost associated, but the outcome for the family and the mother may not be that much more different. And also there are a few challenges that keep happening, new challenges. Nowadays in the 20th century, the moms are older, so there's a little bit more higher chance of complications. Cesarean sections are increasing because there is more accessibility of these of people capable of doing this. Not as much attention given to natural childbirth. Of course, cost of care, and due to obesity, diabetes, and high blood pressure are increasing. So that's pretty much how we can summarize what's going on overall. And we have to mention a few pioneers in OB/GYN in the down the centuries. this is in the ancient world. There were people who were actually doing research on women's anatomy, pelvic anatomy, and diseases of women, doing a gynecological exam, and also, of course, the forceps were first started getting used in the 16th century, and William Smellie is the pioneer for that. In the 19th and 20th century, we were talking about the puerperal infection. Dr. Semmelweis was actually the one who realized that hand washing, which is a very basic thing, reduced the chance of infection in the hospitals. He used a combination of lime and citrus to clean the hands before they touched each patient, and that itself actually decreased the so-called childbed fever. And now more and more surgical repair of vesicovaginal fistula was actually pioneered by Marion Sims. Anesthesia, of course, has evolved over a period of time. Initially, it was, gas, then IV access and morphine injections, things like that. And now, of course, they have the epidural block. We also had some more advances in women's health, gynecological care by Papineau-Nicolau. He developed the pap smear so that we could screen for cervical cancer and decrease the chance of dying from cervical cancer. And of course, ultrasound was a big thing for pregnancy. Without ultrasound, of course, it would be very limited on what we can do. There were a lot of women started getting into OBGYN in the 20th century. Before we mentioned that mostly men were in the field. But starting in the 18th century, later part of the and early 19th century, women started getting into medicine. The first woman who received a medical degree was Elizabeth Blackwell, and also Rebecca Lee Crumpler. She was the first African-American woman who had a medical degree. And once women started getting into the women's health care, they debunked a lot of myths that were surrounding women's health. In the good old days, people used to make up these stories about how the uterus was responsible for, and women did not have as much intelligence, things like that. Because if you had a uterus, you're not intelligent, is how the myth used to go. But it was debunked by a lot of women who were we're actually on par with men. And another woman we have to mention is Virginia Apgar, who developed the Apgar score. This is all things that happen with just observation and analysis, and trying to assess things and take action so that we could have good outcomes. And also, just with the observation, they found the association with birth defects and thalidomide that were used in healthcare. So that is pretty much what I have about how things started going through the centuries. And we have to mention now a short mention about maternal mortality. WHO defines maternal death as the death of a woman while pregnant or within 42 days of the end of a pregnancy from causes directly related to pregnancy or childbirth. So globally, the numbers are 197 per 100,000 births, and you can see Africa, sub-Saharan Africa, accounts for 70% of the global rate. And India accounts for 12%. So in India, currently the maternal mortality is 88 per 100,000. We can compare now with the US is 22 per 100,000. Even US actually spends a lot of money on healthcare, but still their numbers are not as good. But Norway, Poland, and Belarus, they are at 3 per 100,000. The maternal mortality rate is actually decreasing pretty rapidly in India in the last few years. Decreasing in India every year, more in the urban areas, but higher still in the rural areas. And these are some of the projects that the government is taking in order to improve the healthcare of women. And the most common causes for maternal mortality are hemorrhage. And you really can impact this number by having the blood bank facilities. Infections and sepsis, the antibiotics will help with decreasing some of this. Hypertensive disorders and eclampsia, you can detect a little bit earlier if you have good prenatal care services. And of course, with good labor and deliveries, you can recognize obstructed labor and do what we have to help the situation. And of course, women who have pre-existing health conditions, prenatal care is very important to optimize their outcome. We also have to mention the infant mortality. It's measured by the number of deaths per 1,000 live births of babies who are less than 1 year old. Globally, the numbers are 25 per 1,000. 90% are in Africa and Asia. Right now, India is at 24 to 27 per 1,000. But the highly developed nations who have the lowest infant mortality are in Europe and North America. They're 5 to 6 per 1,000. Most of the mortality is because of prematurity and low birth weight, new infection, birth asphyxia, trauma, other severe infections. Actually, later on in life, after the baby is born, in the first year of life, diarrheal illnesses and congenital anomalies. And poverty, malnutrition, inadequate care, poor sanitation also factor into these numbers. How can we reduce this? It's by improving living conditions, safe water, education, access to healthcare, antibiotics, cleaner milk. Fluid and electrolyte replacement therapy has really helped with improving those numbers, blood transfusions, vaccines, and this is all about having those facilities available. Neonatal mortality rate, though, you can only improve with improvement in prenatal care because these are newborn babies and within the first month. Neonatal medicine in some specialized facilities. Actually, surfactant use has really been helping with decreasing the death rate from prematurity. And by also doing prenatal diagnosis, you can decrease the number of babies being born with severe birth defects. And by selective termination, you can, stop those pregnancies. And SIDS awareness for neonatal. So ultimately, taking care of the mother and the baby does make a huge impact to the family. The health and well-being of a woman is important matter for the family, society, and country. And I hope I made it nice and sweet, short and sweet. Thank you for giving me the opportunity to talk at this important occasion. If you have any questions, I'm open to.
Do we have any questions? Okay, so let's move on to our next speaker. So before I announce next speaker, like I said, the QR codes like this one, they are placed around the conference room. So please scan them, and so that you can get your CME, AMA, PRA Category 1 certificates. Okay, our next speaker is Dr. Padmalata Guram. Dr. Guram is a board-certified maternal fetal medicine specialist with extensive expertise in management of high-risk pregnancies, prenatal diagnostics, and advanced obstetric ultrasound. She completed her maternal fetal medicine fellowship at the University of Connecticut and also holds advanced degree in clinical and translational research along with MBA. She currently serves as a chief of perinatal ultrasound and OBGYN residency research director at the Good Samaritan Hospital Medical Center, Catholic Health, New York. Let's welcome Dr. Padmalata Guram. Thank you.
Hi, good afternoon, everyone. Thank you for that kind introduction. I would hope you guys can hear me now. And I would like to commend the alumni for taking this incredible project and successfully completing it. I would also, it's a truly an honor and a pleasure to be able to deliver this talk today. Let me share my screen. Just give me a minute.
Doctor, there is a green icon which says share in the bottom. It's in the middle.
I'm trying, just give me 1 second. So can you see me guys now or no?
We can see you, but the presentation is not visible. You have to share your screen. So when you open Zoom, there is a green button which says share, and it would be exactly in the center.
Yeah, I'm opening up that green button and then it is taking me to...
You have to select entire screen.
Screen.
Enter it. Yeah.
Dr. Gurram?
Yeah, I just sent Afreen a screenshot. So it's not letting me move. Should I log back in and try it?
You have to select that screen. You have to click on the screen, then it will, yeah.
Yes, I'm clicking on the screen and it's not taking me to the presentation.
Sure.
Cancel it.
Dr. Gurram?
Yep.
Meanwhile, can we continue with a different speaker in person here? We'll troubleshoot your system by then. I'll connect to your system directly.
Yeah, or if you want to put in you guys have the slides, right? Will you be able to move the slides for me? Whatever is easy for you guys.
Yes, we can do that. But I want your video to be on. Right now it's off.
Okay.
So Afrin will share the presentation and you can start speaking. Doctor, you can start now.
Like I said, I chose this topic because this is a new 21st century phenomenon, which is purely iatrogenic, and diagnosing it prenatally and treating it accordingly will save lives. Next slide, please. I do not have any financial disclosures. Next slide, please. So each of the objective can be by itself an hour-long topic, but I will touch base on the salient features and move on to show some cases if the time permits. Next slide, please. So why is this important? It's in the maternal mortality can vary from about 7% in countries like low-income countries to about 0.05% in high-income countries. If there is no prenatal diagnosis, it can be up to the maternal mortality can be up to 30%. So it is potentially a preventable problem, and the common reason why this happens is lack of awareness. Number one. Number two is that severe hemorrhage, not able to control the bleeding, and lack of expertise. Next slide, please. So the preferred current terminology is placenta-accreta spectrum disorders, and it is an umbrella term that is both preferred by ACOG and FIGO. The older terminology, accreta, increta, and percreta, that is used in isolation because it's a histopathological term. It doesn't include any clinical or intraoperative findings. Next slide, please. So FIGO came up with in terms of like standardization of the definition, and all of us can speak the same language. FIGO included the clinical, intraoperative, and postoperative findings, and came up with a new classification where the grade 1 is where the placenta is directly attached to the myometrium. Grade 2 is it will invade into the myometrium, and grade 3 is invasion into the serosa, and further divided into grade 3A, B, and C. So what's the reason for what's the reason for this increase, and why did we get here? When I'm a postgraduate, it is only in textbooks that we used to hear about it. So the reason for the dramatic increase is that because of the rates of the C-section. So if you, as you can see, in 1950s, the C-section rate is about 4.5%, and the past incidence is 1 in 30,000. And now the C-section rate is about 23%, and we are seeing it in 1 to 3 per thousand births. So what are the main driving factors? The main driving factors are the C-sections and the placenta previa. And the C-section is the higher the C-section rates, the higher is the previa. So as you can see, the first C-section rate, if you have one C-section, one previa, it is 3.3% incidence. If it is 4 C-sections, it's going to be about 60%, which is a dramatic increase. Next slide, please. So what are the other risk factors involved? The three other risk factors, the main risk factors to keep in mind is advanced maternal age, prior to trained surgeries like myomectomy, and IVF pregnancies. And the other important thing to keep in mind is if we see elevated AFP, we want to keep looking for the placenta previa in addition to the other features that you look for in AFP. Next slide, please. So what's the pathophysiology in placenta accreta spectrum disorders? Traditionally, it was thought that it invades like a cancer, and it's normally when you do a laparotomy, you never see placenta being or on the serosa or invading through the serosa. It's always covered by the serosa. Next slide, please. So the new concepts are that it's primarily a disease of the uterine scar. So what it looks like with the scar, the dense scar with the new blood vessels growing into it, looks like an invasion, but it's actually a deficiency of the, it's a defect in the implantation rather than it's a problem related to the placenta. Next slide, please. So as you can see, picture A is normal implantation, picture B is abnormal implantation. So what happens when there is a previous C-section or when there is a scar is that there is defective decidualization, and the anchoring villi, due to lack of trophoblast, due to lack of the normal tissue, migrates all the way to the top of the uterus where you have blood vessels. These blood vessels are high volume, high velocity, and they lead to formation of lacunae, new blood vessels, and also fibrinoid depositions, and then it becomes an adhesive disease. Next slide, please. So it's actually, so why does it matter whether it is an uterine cause or it's a placental cause? Because we know now it's a problem with the scar. Number one, we can avoid unnecessary C-sections. Number two is that we can repair if we have to. A good repair will lead to a better outcomes. Next slide, please. So the key tool in diagnosis, how do we diagnose this prenatally? And then the key tool to diagnosis is by ultrasound. So there are certain ultrasound markers in addition to the risk factors. If we assess, we can accurately diagnose based on the ultrasound itself. So on the you can see both the normal placenta and the abnormal placenta. In the normal placentation, you can see uniform echogenicity without any placental lacunae. And here on the right-hand side of the screen, you can see that there's multiple irregular lacunae. The more the number of lacunae, the more the blood flow is, higher the incidence of placenta accreta. Next slide, please. You can see the placenta lacunae if you put in the color how there is a blood vessels going into it. So by itself, you can see even in normal placentas, but if it is associated with other features, then it can be a marker for placenta accreta. Next slide, please. So this is the second feature that we look for. This is a transvaginal ultrasound. You can see the picture image of the cervix along with the placenta. As you can see, there should be a normal hypoechoic space between the placenta and the cervix. But when the space is lost, you can see when there is a placenta accreta, you see that there is a loss of the scar tissue. There is a loss of the space, the normal hypoechoic space. Next slide, please. The next thing is that looking at the thickness of the myometrium, you can see that there is a normal thickness. Any thickness of any myometrial thickness that is less than 1 millimeters, as you can see here, you can see that this is the bladder, this is the transabdominal images. You can see that here is the bladder, here is the uterine bladder interface, and then you can see that the placenta, how there is no absolutely no myometrium here. So looking for the thickness of the myometrium is also important. Next slide, please. So you can see this increased vascularity beneath the placenta, the placenta. And then, so it's important to look for those three factors when you're looking into the myometrium. So loss of space, number two, the thickness of the myometrium, and increased vascularity. Next page, please. So you're looking at the uterine bladder interface and looking at the vascularity here, how you can see the multiple blood vessels running through and how you can see the interruptions. And you also want to pay attention to how the blood vessels go across the bladder wall. Next slide, please. So again, normal uterine bladder interface, you should see a clear white line. And here in the slide number A, you can see that there is multiple lacunae here, multiple hypoechoic spaces, and how irregular it is. So this also gives you a clue to it could be a possibility of accreta. Next slide, please. Again, when you put in the color, you can see the blood vessels going into the uterine bladder interface, and this tells us that it is a marker for, the blood vessels are penetrating into the bladder, and it could be percreta. Next slide, please. So the placental bulge is another marker. Again, these are all transabdominal pictures. You can see here is the bladder, here is the uterine bladder interface. It should be a clear white line like this. But here you can see that it is invading into, or it is protruding into the bladder, which is again a hallmark of placenta accreta. Next slide, please. So this is a transvaginal ultrasound here. The asterisk is the bladder, and you can see the bladder uterine interface, the blood vessels, and the placental bulge going into the bladder. Next slide, please. And you can see, again, putting on the color, you can see how the vascularity is, how you can see the interruptions. And here is the placental lacunae. Next slide, please. And you can also see that there is placental thickness, increased placental thickness across, where the site of accreta is. And the normal placental thickness, when you compare it with the normal area, you can see that there is an increased thickness where the accreta is. Next slide, please. So the question that we get asked is that which sign is the best sign for as an ultrasound marker? So there is no individual. So you have to think about it in a clinical perspective. So if there is a risk factors, these markers become more significant. Let's say if the patient has 3 C-sections and the patient has all these markers, then the probability of having an accreta is higher. Next slide, please. So here in US, we tend to do MRIs too. And what's the role of MRI? We use MRI when the diagnosis is doubtful, more in case of where we want to rule it out rather than ruling it in. So when there is pelvic organ involvement, or when you want to evaluate the evaluation of the posterior placenta. Next slide, please. Coming on to the management, the key points in the management is that you want to deliver the patient before the patient goes into labor. The delivery is recommended between 34 weeks of gestation to 35.6 weeks of gestation. And we tend to deliver the patients if they have earlier comorbidities, such as any bleeding or any rupture of membranes. We definitely give them steroids. We give them betamethasone, and we also give them magnesium sulfate for neuroprotection if they are less than 32 weeks in gestation. And in US, we do not go for conservative management. It's considered to be investigational. Next slide, please. So we tend to deliver these patients at level 3 or level 4 maternal care centers where we have all the expertise available. The studies have shown on and on again that when you have the entire team involved in terms of fetal medicine specialists, anesthesia, and pelvic surgeons, including either oncologists or urologists, and having blood bank, neonatologists, interventional radiology will help the outcomes. So it's always better to deliver these patients in centers where in referral centers where you have all the team available to avoid catastrophic emergencies. Next slide, please. So we do counsel the patients extensively in terms of hysterectomy and need for blood transfusions and injury to the surrounding organs. And intraoperate. And what we do is that normally we do have our multidisciplinary team meetings before the delivery, at least a week before or 2 weeks before, so that we can all of us are on the same page, and including anesthesia, NICU teams, and the surgeons and who are involved in the case. And we do include the blood banks so that they can be ready with the transfusion protocols. So what are the keys? So anesthesia is the key. So we do start them with general anesthesia. We do start them with the spinal or epidural, and we proceed to general anesthesia after the baby is born. And most of the times the patients do have A lines. And also their patients are monitored with point of care tests intraoperatively for any electrolytes, blood gases, and we also give them the prophylactic antibiotics. Cefazolin is commonly used, and if we are proceeding with the hysterectomy, we tend to go with, we add flagyl. And intraoperatively, what we do is that if resources are available, we also help them with intraoperative ultrasound with a sterile ultrasound, so that we can map the placenta and see and advise them to where to make the incisions. So uterine incision should be made away from the placenta. We tend to leave the placenta in situ, and we close the incision. The skin incision, going back to the skin incision, most of the surgeons prefer to go with the vertical midline incision, but sometimes we also go with depending on the patient preference, we also go either with wide Fannin steels or the Maillard's incisions. And in terms of uterine incisions, stay away from the placenta and deliver the fetus, leave the placenta in situ, close the hysterotomy scar, and proceed with the hysterectomy. We do have massive transfusion protocols, and where we give either 1:1:1, meaning 1 unit of packed RBC along with 1 unit of fresh frozen plasma and 1 unit of platelets, or it can also be 1:2:2. And we, after the procedure is done, we do transfer these patients to ICUs and monitor the patients in the ICU if needed, depending on the blood loss and how the patient is doing. In terms of cystoscopy and urethral stents, it's case by case. If we think that the patients need these cystostomy, if we think that the bladder is involved, then or ureteric involvement is a possibility, we tend to go for stent placement, but it's not a routine. It's by case. And the same thing with the pelvic, with the artery balloons for control of bleeding. It's also case by case. It's not a routine. And it's depending on how the patient does, we transfer the patient either to the SICU. And the other important thing is anticoagulation in the operating room. Depending on the risk factors, we do go with the compression, mechanical compressions, and postoperatively, we do use heparin or Lovenox, depending on how the patient is doing. Next slide, please. So the hemorrhage control is the key for for saving the life of this patient, for these patients. Since we diagnose these patients at 18, 19 weeks, we tend to optimize hemoglobin prior to delivery, either with oral iron or with IV iron infusions. And intraoperatively, as I mentioned to you, it's massive transfusion protocols in place. And we also give prophylactic tranexamic acid or TXA. Either we give it before the skin incision, after cord clamping, or even after the delivery after the procedure within 3 hours. And the other recombinant factor 7A is hypogastric artery ligations, pelvic artery embolization, compression of aorta, and pelvic packing is when we are not able to control hemorrhage or intractable hemorrhage cases. So optimization of hemoglobin, massive transfusion protocols in place, and prophylactic TXA is part of routine. Next slide, please. So let's say if we get into unexpected intraoperative diagnosis, or we see it intraoperatively, we did not diagnose it, what are the best outcomes? So try to take a pause and then alert your staff, mobilize all the additional expertise, mobilize your anesthesia team, your OR team, and also the blood banks. And if deliver the baby, close the uterus, and if you have expertise, go ahead and do the hysterectomy, but don't try to forcefully remove the placenta because we're going to land in bleeding. If the facility lacks expertise, and if the mother is stable, you can always close the hysterotomy and abdominal incision and transfer the patient to a facility where they have expertise. Next slide, please. Next slide. So conservative management is where the protocols in ACOG and RCOG differ. We do not, it's only reserved for selected cases. The reason for not proceeding with the conservative management is because most of these cases end up with hemorrhage, infection, or delayed hysterectomy. And in UK, yes, RCOG guidelines tend to be if feasible, you can do partial resection. So one of the procedures that is gaining attention in UK is triple P procedure, where they make the incision away from the placenta. They leave the placenta in situ, and along with the myomectomy, along with the myometrium, they tend to remove the myometrium and repair the scar. They also use the pelvic artery balloons for better control of the hemorrhage. Next slide, please. So I want to touch base a few slides on C-section scar pregnancy, because this is most of the cases are diagnosed at 16 or 18 weeks for placenta accreta. The new, if we are seeing signs, what are the signs in the first trimester? And then what we call it as C-section scar pregnancy, or the pregnancy implanting within the C-section scar. And it is considered to be a continuum of placenta accreta. As you can see in this picture, it's a transvaginal ultrasound. It is, the sac is located in the lower uterine segment, in the uterine C-section scar. Endometrial cavity is empty, and see the whole endometrial cavity is empty. And here is a C-section scar, very thin myometrium between the bladder and the implantation. It's usually diagnosed between 5 to 7 weeks. After 5 to 7 weeks, because the sac migrates towards the fundus, it's hard to diagnose it. Next slide, please. So how do we diagnose it? So transvaginal ultrasound is a must. And if you divide the uterus in a longitudinal plane into half, and then you divide again using a perpendicular line into two sections. So this is the first line you draw on the sagittal view, and perpendicular to that you draw another line, dividing it into half. And if the sac is situated anterior to this perpendicular line, that means it's a normal pregnancy. If it is situated beneath that perpendicular line, it is a C-section scar pregnancy. Next slide, please. So there's two types of C-section scar pregnancies. One is if it is situated within the scar tissue, or it is situated within the defect or the niche of the C-section scar. So if it is situated within the scar tissue, it has a better prognosis, and you can see a normal myometrium here. The thickness of the myometrium at least 2 millimeters or more. And if it is situated within the defect of the C-section scar, the thickness is very minimal. Next slide, please. So again, the same picture. So here is the C-section scar. And you can see that the sac is situated within the C-section scar. And then here you have, you do not have, here it is a defect in the C-section scar, and there is absolutely no myometrium. Next slide, please. So why is it important? Because general expectant management is not recommended. And if possible, if the patients decide to go into expectant management, delivery is recommended at 34 to 35 weeks of gestation. And next slide, please. It can be catastrophic, so it's important that we diagnose it in the first trimester. The management is operative dissection is the management, where you use either transvaginal or laparoscopic approaches, and you remove the pregnancy and you repair the defect. That has better pregnancy outcomes. And more, we're also hearing about the double balloon catheters, where the Cook's balloon that you use for induction of labor can be used. And then one balloon goes into the uterine cavity, one balloon stays next to the sac, and it has shown to have better outcomes. And gravid hysterectomy if the patients don't desire fertility. Next slide, please. So systemic methotrexate that is commonly used for ectopic pregnancies is not recommended. You can use intragestational methotrexate with other treatment modalities. So please advise the patient that there is definitely increased risk in the future pregnancies, and try to bring the patients in the next pregnancy in the first trimester. Make sure that it's not a C-section scar pregnancy. Next slide, please. All right. So a couple of cases. Here we have a 29-year-old patient with a one prior C-section, and we diagnosed her at 18 weeks, and the patient presented at 31 weeks, with bleeding. So the pre-op hemoglobin was 10 grams. We gave her antenatal steroids. We gave her magnesium sulfate, and we also gave her preoperatively 2 units of packed RBC. Next slide, please. So here is the ultrasound images. As I mentioned to you before, you can see how there is a lack of uniformity in the uterine-bladder interface. You can see multiple lacunae, and you can see the blood vessels going into the bladder. Next slide, please. Next slide. Yep. So here again, we involved all the team, and the patient underwent TAH. There was a significant amount of bleeding where there is 3,000 cc's. We had to do hypogastric ligation too. And most of the times we do total abdominal hysterectomy as opposed to supracervical because of the vascularity in the lower uterine segment. And the patient did very well post-operatively, and the pathology was in Creta. Next slide, please. So you can see that, again, it's a history of, this patient is, again, had a 20-week demise, came in had a classical C-section at 24 weeks. And in the third pregnancy, we saw her. And because of the history of cervical insufficiency, we put in a cerclage, and we diagnosed her at 16 weeks. It's attached right where the classical C-section scar was. And the patient got admitted with short cervix at 24 weeks. Next slide, please. So you can see multiple lacunae here, and then you can see the vascularity here. And next slide, please. So the patient is, you can see it's a transvaginal ultrasound. The cervical length is about 1.4 centimeters. And you can see how short, how short the cervix is. And you can see the stitch here. Again, multiple lacunae with vascularity. Next slide, please. Next slide. So the same protocols in patient, we admitted the patient. So whether we admit these patients or not, outpatient versus inpatient, depends on how the patients are doing. If any risk factors, we admit them. Most of these patients, if no bleeding, no other risk factors like short cervix, we tend to manage them as outpatient. So the patient underwent supracervical, had a cystoscopy because we were strongly suspicious of erythral involvement, and they had to do a repair of bladder injury, and the pathology was placenta precreta. Next slide, please. In case of C-section scar pregnancy, we saw the patient at 5 weeks of gestation, and you can see the C-section. So transvaginal ultrasound, cervix here, C-section. This is the bladder wall here. You can see the C-section scar. And the patient underwent a laparoscopic resection and closure of defect. Next slide, please. Next slide. So another case where the patient was actually referred to us at 8 weeks because of they were suspecting C-section scar. Patient had one prior section, one abdominal myomectomy, IVF pregnancy, AMA. And patient, we diagnosed her at 8 to 10 weeks. Patient wanted to continue the pregnancy because it's an IVF pregnancy. And we did give her preoperatively, during the antenatal period, IV infusions, and preoperatively to receive 2 units. Next slide, please. And you can see when she came in at 8 weeks, you can see how the scar is within the lower uterine segment. And it's almost like type 1 C-section scar pregnancy because you had a good myometrium there. Like I said, by the 11 weeks, it will look like any other normal pregnancy. Next slide, please. So this is the picture at around 16 to 18 weeks. So you can see how the placenta is. So bladder here, cervix on this side. You can see how the placenta is and how ugly and irregular vascularity you can see here. Next slide, please. So again, the same protocols involving all the team. We delivered, the patient wanted his fan and steel incision. So the fan and steel incision was given, spinal anesthesia converted to general anesthesia, A lines, and C-section with total hysterectomy. And they had to do an intentional cystotomy because it was invading into the dome of the bladder. And the patient did very well post-operatively. Pathology was placenta precreta. Next slide, please. So the key take-home messages is accurate antenatal diagnosis, having a high suspicion, and involving the teams and delivering at centers where there is expertise, deliver them at 34 to 35 weeks, and delivering them with, delivering the baby, leaving the placenta in situ, and then doing a cesarean hysterectomy, and being prepared for the high volume blood loss saves the lives. Next slide, please. So be aware of the C-section scar pregnancy. It's not rare, and it is increasing with rising C-section rates. and C-section scarred pregnancy and placenta accreta spectrum, they represent a single disease continuum, and early detection, with early detection, the patient can have future fertility options. Next slide, please. Thank you. Thank you for the opportunity again. I'll take any questions.
Yeah. Dr. Lal, Sunil, could you please go to the mic? Dr. Guram, we have a question here.
Okay.
Good afternoon. This is at the outset, I would like to congratulate Padmalata. I think it's same Padmalata whom I know. I'm 1 year senior to you. Is
yes,
it?
Anu.
Yes.
Yep. Good to see you here.
You are JH classmate?
Yeah, I am JH classmate.
Yes,
and
yes.
Yeah, and,
yes, I think I'm 1 year senior to you. Right now, I'm heading. I'm the professor OBGYN in our GMC, and I have just a couple of questions. One is, as you are telling, it's iatrogenic, definitely. And what about this? Because post IVF, other than the scarred uterus, you have PAS spectrum in cases post IVF because of the changing in the estrogen atmosphere, like maybe extremes of estrogens, maybe too high estrogen or a low estrogen with a thin endometrium, that predisposes to, that is going to affect the implantation, and that results in PAS, especially non-scarred uterus. So that's what I wanted to add. Okay, it's not a scarred uterus, it's a non-scarred uterus. That's one thing. And second one is, I mean, do you have any idea about any soft markers? Okay, other ultrasound definitely, and other than the ultrasound, any soft markers in a very early pregnancy, like less than 12
I
weeks?
cannot hear your last question. I'm sorry, you're frozen on my screen.
If you don't mind, could you repeat? It seems
what's your experience? What's your experience regarding the incidence of PAS in non-scarred uterus, especially post IVF?
So post IVF, definitely I agree with you. It's not only in scarred uterus, while scarred uterus and the placenta previa are the main driving factors. The two other risk factors we pay attention to is, one is AMA, advanced maternal age, if mothers are, which we commonly see here, if the mothers are 40 years and above, that's a very big risk factor. And the second risk factor is IVF. Definitely we do pay attention to it. And I also think that with the IVF, it is a little bit easy. We should be able to make an early detection because, these patients undergo more serial ultrasounds from the beginning of the pregnancy itself. So we definitely, those two are the biggest risk factors in addition to previa and C-sections. And the other question is about the soft markers. So one of the soft markers is AFP. So if you have an elevated AFP, in addition to looking at the fetus, you definitely want to pay attention to your placenta and make sure that we're not dealing with any accretus here. And good to see you, Anu.
Okay. And one more thing is, do you routinely go for soft marker estimation in the first trimester?
So in the first trimester, it's becoming less and less frequent. So we definitely go with only, since the start of NIPS, NIPT, we are not doing the first trimester markers. It's not a part of routine protocols for us. So it's only the AFP at 16 weeks is the only marker that we do. It's mainly of the ultrasound. I think as far as the accreta is concerned, I think we definitely rely. Most of our cases are diagnosed by 16 to 18 weeks because most of our patients have anatomy scan. The protocols are that whenever we do the anatomy scan to evaluate the placenta, whether they have C-section or not, whether they have previa or not, to evaluate thoroughly. And we do, in our ultrasound reports, we do put in whether the patient has sonographic markers, whether the patient is low risk or high risk for PAS. So I think it's one thing to, not sure if the OBs are doing ultrasounds there or the radiologists or the fetal medicines or specialists are doing in India, but it's ideal to ask them to put it in your ultrasound reports so that you are aware, especially if you have risk factors.
Need not be a scar all the time. That's what I wanted to share with you, because we do come across with so many cases of course, especially in government service. We almost day in and day out, we are getting so many cases of PAS and even non-scar also. That's one thing. And second one is regarding CSP, cesarean scar ectopic pregnancy. Recently, we had one experience of this thing with, we have treated it with a curettage. Simple curettage helped us. That's what we wanted to share. I think Dr. Jansi also, she is going to, okay. And we recently had one case of CSEP, and which was referred from outside. It was given methotrexate outside, and we were really in a fix whether to go for a lap as suggested, recommended, lapse resection and then suturing of the scar. That's really hectic. And in a government setup, actually, we really could get out of the crisis by doing a simple curettage. I think that also can be added. Is an armamentarium for the treatment. That's what I wanted to share. That's all.
Yeah, definitely. It depends on where we are, what resources.
I think that's only last 2 months before. I think, madam, only 2 months back we could treat it with a simple curettage.
Right. So I put in the recommended treatments, and so in addition to, I think if you know, obviously if we don't have resources, I think the best way to go is you train aspiration if you can, rather than a sharp curettage, because you can land into hemorrhage. Obviously, whatever works and whatever we have is that what we have to work with, right? So I think intrathecal methotrexate is preferable. If you don't have intrathecal, and if you don't have the resources for intrathecal, obviously you have to go for systemic. So it depends on what we have. But I just put in what the current guidelines are there at this point. And I agree with you. It depends on the resources and what is available at that point.
Okay, this is only to share our experience at GGH. Okay.
No, definitely. Yeah.
Okay, anyway, nice meeting you, Madma.
Yep.
Okay.
And we also have, please go ahead. And we also have online questions. We have like a few physicians joined us. So please go ahead, and then we'll go with the second question.
Madam, this is Dr. Aruna. Madam, I am a professor in HOD of OBG department in DGH Guntur, madam. Just I want to share you that in our hospital, this is a referral hospital for this entire Guntur district. We are getting many cases of placenta accreta spectrum, and all professors or faculty are able to do these cases and reduce that maternal mortality in those cases. Wow. And we have done many cases of this PAS, cesarean hysterectomies and intraneal ligation, and we could save the patients. Wonderful. So we get all the cases. So we are doing that. That's point we want to share with you. Thank you, madam.
No, that's very good. Thank you for sharing. And it's incredible how far we have come. Even when I did my post graduation in KGH, so here in India. So from that time to this time, I do speak with my colleagues, and it's an incredible how we are able to do all the things that we do here, actually, in India too. So that's great. Thank you.
Wonderful. We have one question online. We have few physicians online, and this is only one question we are going to ask. And then we are going to take a 10-minute break because Chief Minister's bomb squad is here. They just have some formalities to finish. So the question here is, Dr. Guram, what is the role of intra-sac kid in CAP? KCAP.
I'm sorry, can you repeat that? Intra-sac?
Intra-sac. Okay. Potassium chloride. Go ahead.
So you could also do that if you have a fetus with a heartbeat, and if you want to, because most of the times we are able to handle that with methotrexate. Methotrexate has shown to have better outcomes in the first trimester. It's not that, with the KCL is usually used for much bigger fetuses, more in terms of the second trimester, at least in US, based on our experience. So for first trimester, if you're talking about the C-section scarred pregnancy, we tend to go with the intrathecal methotrexate. I'm trying to remember if we had done any KCL. So KCL is mostly for second trimester. And there is also a controversy about the term, whether it is a C-section scarred pregnancy or an ectopic pregnancy. It's different. We prefer not to call it, but SMFM still calls it as an ectopic pregnancy because it has normal outcomes, and it's a completely different management. Just on a side note.
Wonderful. It's amazing with the Wi-Fi, the time gap and also the technical difficulties. Dr. Guram, you and Afreen, you guys pulled it very well. We didn't feel anything odd or anything here. And then our next speaker, Dr. Meenakshi is here, but we have to take 10-minute break, and then we can come back. So let's clap for Dr. Guram. You did an awesome job. Thank you so much.
Thank you.
Recording stopped.
Yeah. Shall we start again? That's okay. Finish your picture. That's okay. We'll. Okay. Dr. Lal, could you please get them in? I can see. Okay. We'll start now with our third speaker of the evening.
Recording in progress.
Okay. We have few physicians joined on the Zoom. So Dr. Meenakshi, we do have 17 speakers. 17 physicians on the Zoom. That's why we are recording for them. Okay, so this is my pleasure to introduce our third speaker of the evening, Dr. Meenakshi Chintapalli. Dr. Chintapalli is a highly respected, board-certified pediatrician with over 4 decades of experience in general and behavioral pediatrics. A former clinical adjunct professor at UT Health, San Antonio, she is nationally recognized expert in early brain development, child behavior, and parenting education. She is also founder of Sai Educare, an organization dedicated to helping children achieve their fullest potential. Let's welcome Dr. Chintapalli.
How many of you are pediatricians? None. You all have kids. How many can benefit from early brain development and handling current problems? See? Okay. Good evening, namaste, good afternoon. Depends upon who is listening from where. I'm Dr. Meena Chintapalli. Where do I move, Amma?
Here is
this one? This one?
Yeah.
Okay. So my responsibility is to make an impact so that everybody learns whatever the problems that you are seeing today. As an internal medicine doctor, OBGYN doctor, or anybody having some problems, even with the children of your own, grandchildren, is related to what happened in pregnancy, what happened in the first 24 months. Because now this data that is available is about 50 years old. Who has heard about first 1,000 days buzzword recently? Anybody heard about that? Particularly in India, that's very popular. Particularly that is very being sold by UNICEF because that is considered as grade 0 level of education. Are we teaching children? Are we teaching infants? No, they are already learned. It is called as theory of mind, implicit learning. They already have curiosity, motivation. They know if you are intentional, not intentional. They know if you are angry. They know how to learn about their world. So the aim here is to bring about the most opportune time and anything that you want to do to create an Einstein and to prevent developmental disorders, what is now technically called neurodiversity. Structurally, functionally, the brain is organized in the first 24 months, starting in the uterus. And why is this opportune time and responsive caregiving, early relationship is tied into the whole lifetime abnormalities and neurodiversity, learning disabilities, ADHD, oppositional disorders, depression that we are seeing, because we are at the crossroads of mental health that is compromised, from infants with a high prevalence of autism to adult. Second leading cause of death is depression. And the goal is, some of you, hopefully I saw more medical students, hopefully I saw more pediatric residents, who are the younger generation who could take it to their heart and implement so that they can create a genius. As Einstein said, geniuses prevent problems, intellectuals try to fix a problem, okay? So the optimizing the social emotional learning is the goal by teaching every parent. I have no financial incentives, but I have written books on this since 2004, and I was one of the pioneers in creating the multisensory integration for an optimal child development, even with 1-pound babies who were told they would become vegetables. What if the guiding principle tells us everybody knows about the nurture, everybody knows about the facts about converting a fluid status of the brain into a solid architecture that has all positive pathways, which we are trying to implement right now, of lifestyle management. We can prevent obesity, we can prevent metabolic disorders, we can prevent hypertension. Not only that, we can prevent neurodiversity. And so the most important thing is how children are really shaping up with linguistic abilities, cognitive development, and social emotional learning with a relational bonding with the parent. Are we giving that with 2-income families? The developmental theories that are very, very popular right now is Mary Ainsworth attachment theory, where we are failing as a global humanity because we are unable to realize the early relationship is very important. Ecobiological, now the chronocosm of the disasters, the state of America right now we are in, and the impact it is having on the lives is going to manifest definitely with the natural disasters in about 3 years. But could that have been prevented if our microcosm, mesocosm, macrocosm has been stabilized with a universal protocol and a system? Maslow's hierarchy, when we give fundamentally a basic support to an infant to establish the basic developmental abilities. Gardner's multiple intelligence theory is not so much popular because we know everything is so dynamic. It is happening so simultaneously because God has given only 5 senses to connect with the world, okay? And so this information is nothing new. 50 years, nobody has implemented in their practices. Okay, let's go. That slows me down. Why is it not moving, guys? I need to go to the next slide. Next slide, it's not going. Okay, so the brain connections, 90%, it's the architecture, right? Brain is a soft, fluid bunch of cells, 100 billion cells at the time of birth, and it is by the second birthday, when the first 1,000 days, 275, is pregnancy, emotional stress, Garbha Samskar. We are going back to the Aryan civilization that protected the pregnancy, gave happiness to the mother, and I can show you those signs, some of those slides that will help you. The brain volume is a gray matter in the first year. By 12 months, they are completed. And it is through interpersonal relationship, never through the iPad, never through the tablet, never through the iPhones, or through the screen time. It is mother and child, or the father and the child, particularly 10 IQ points will be more. In gray matter, 101%. The synaptic connections that determine the ultimate connectivity from outside to inside, bottom up to this frontal lobe, is 149% completed and only 11% later on in the second birthday. The white matter, which represents forming these wires like within the wall, that is connected to the light, personality or voltage of the personality, it happens after the second birthday based upon the experiences the parents give. Cerebellum is very small. Those are the references there on the slides. Cerebellum is very small and amygdala is very large among the autistic children. The cerebellar worms. The cerebellum growth has completed in 280% of the times within the first birthday. If we look at the congenital heart diseases, we spend so much time on super specialty. You just heard 95% of the deliveries are normal, and we have normal term babies. And why are we seeing so much of mental disorders, mental, emotional, behavioral disorders, neurodiversity? Globally, the congenital heart disease is 9 to 10 out of 1,000 live births. In India, it's 0.6 to 1.8%. Chronic kidney disorder, globally 1 to 3%, India 4.9%. Acute kidney compromise is because of shock or hypovolemia, sepsis or whatever. The high mortality rate is not a preventable, but it can be preventable if you have a better life practices. Non-alcohol fatty liver disease globally is 25%. It is the eating habits as well as infections in the majority of the times, and if that can be preventable if vaccinations are given. Asthma is another cause that is causing high morbidity, 4,758 per 100,000 children. Globally, cancer is 103 to 178 million. But look at the mental health disorders, 50% of the population, 900 million, this is for the World Health Organization. The most top of the list is anxiety, 40% after COVID, even by the 6th birthday, and bullying, neurosis, depression, PTSD, lead exposure, ACEs, toxic. You must have heard about these buzzwords all the time. Why should they affect every child? Who is doing something that is to prevent the resilience and thriving capacity of the nerve connection outside to inside? What is causing these children to survive and just not thrive? The vulnerability. It's not always the money, it's the relationships. It's what we can teach through our peripheral community outreach programs, SPM, our medical students can be trained, ASHA workers can be trained, Anganwadis can be trained, because 70% of the population here is village. How to take care, how to give relationship, okay? And so I'm not going to go back to the statistics again. As I said, 40% anxiety, neurosis, behavior disorders, 20% of neurodiversity by the time the child is 11 years old, 13 to 15, mood disorders, anger management issues, and instant gratification, impulsivity. 15 years and up, 11.4% already having substance use disorders. Anybody can look at some examples of what I did with the neuroplasticity on my website, mychild-educare.com. So the second leading cause, it's kind of worrisome. I'm sorry, I'll just go past all these. Statistics are available online. I really want to get to the nitty-gritty matter. So as you see, 50% of the population by 2030 are going to have mental disorder, out of which 49% suffer from mental disease issues that can be prevented and cannot have a doctor's visit. 12% of the girls having major depression, but it's actually more between 18 to 34 years. Who says 34% of the population or 40% of the population are having mental disorders and they are raising children? So the most prominent is 41% of anxiety, depression, and stress-related disorders. Stress causes more problems physically also. If you look at this, if you look at this slide, if you look at those synapses on the optimal window, 100 billion cells at birth, and you're also seeing Dr. Chugani's slide, at 1 month, there was nothing other than limbic system, which is very, very prominent. The child knew the intentions of the parent. The child knew if it is being cared for. The child knew, had a curiosity to explore. Why is child, an infant at 12 months cruising, is prone for accidents? They explore the environment. We are preventing the exploration. We are preventing exploration of the green spaces and nature. We are not really giving them opportunity. It is not related related to poverty or inequities or, the situation at home. It is related to what we can tell the parent, how to engage them during their routines, to give them that love, give them that responsive caregiving. If between 1 month to 3 months, if the limbic system is not set to have the state of security, being loud or asking and feeling that I'm very important in this family, I'm being loved by this family, I can do a lot of things. They talk to me about my body parts. They talk to me about the baby animals that I see. They're looking at your mouth. They're looking at your cause and effect associations, but they're immobile at that time. The complete buffering is done by the adult who is completely in control of their own emotions. And by 3 months, if they feel so secure and everything, they're connecting already with the prefrontal cortex. That gives them an opportunity to build self-reliance, self-regulation. But are we teaching the parents that you need to redirect your child if they're crying with separation and stranger anxiety? That is so important that we should pay attention to, because don't pick up a child when they're crying. You do need to pick up a child until that time, after 45 seconds of crying, to give instant gratification for them, the belongingness. But after that, you need to move to become a parent, becomes a teacher at that point of time. And so we get a physiological immunodeficiency. Are we balancing the nutrition with the herbs that are available, like ginger root, turmeric, and peppercorns and everything, made homemade food with the millets and other things? That can prevent obesity. That can prevent food allergies in the future, like peanut butter or some peanut powder. But it has to be safely guided so that that particular child doesn't develop allergies, rather than feeding a lot of white carbohydrates. We can hardwire them, because there was nothing before, everything connected with the world at the time the child is being reared, up to in the first 12 months. By 12 months, you see how the connections have happened, synapses have proliferated. The brain already knows what works for me, what doesn't work for me. Do I belong here? Do I not belong here? If there is a scarring, which you are seeing here, I don't know, there is no cursor, sorry. So that has a, that scarred brain has a deficiency, quantitative deficiency of serotonin, dopamine, and learning hormones, happy hormones, melatonin. So no wonder you must have heard about sleep disorders in everybody who has some emotional problem, or neurodiversity, autism spectrum disorders, ADHD. They have problems with sleeping. And that is because of that scarring. If a child, an infant, instead of connecting 250,000 cells times 10,000 connections, the synapses per each cell, 3 million connections per second. If you don't use them through multisensory integration, you lose them all. And you lose 600,000 cells per second, which is 9 million connections per second. How much are we losing if the child is not hearing? Nobody is doing a hearing screen on them with acoustic reflectometry after 1 year infection. There is a fluid buildup for about 60 days. And if it's the child is going to have a learning disability and speech disorder and articulation processing disorder. And so everything can be prevented if you do well with the social emotional learning, and I'm going to go through that later on. Okay, here is an example, of how those things, if there is no sensory signal with the relationship with the grown-up, the messages are not there. The child shuts down. They shut down their ears, they shut down watching, they're looking at you, but they're not noticing you. And do you remember the autism spectrum disorder behaviors? This signal doesn't happen. The synapses, and they do not have internal wiring, as you see here. They do not. They have a way of shutting down the senses, and we lose 6 million of them. What causes from outside to inside? A thread that creates If you just show cards, if you just show a screen, only the occipital brain is connected, as you see. But if you have talking, you are firing the Broca's area, which also wants to talk. Where there are mirror cells, there is a motivation for the child. Oh, you're talking to me, I know. But 3 to 5 times they make a word-object relationship, and that's how you encourage speech. Why are we seeing speech delay? What happens, most of the times, I've seen this in this country, and even in USA, the Indians who come there. వాడు 4-5 ఏళ్ల దాకా మాట్లాడలేదురా, నువ్వు కూడా మాట్లాడలేదు, పర్వాలేదా డాక్టరు ఊరికే చెప్తా ఉంది. Don't do tummy times. She'll break the bones. She'll break the neck. All these things are myths we need to remove. There is a curriculum that the child need to follow. And that curriculum is based upon emotional relationship, not like what you give a story and you learn a factual information when the baby is already 3 to 5 years or 5 in the secular education. That's not what we are talking about. Shanice has described how the relational health creates a curriculum through your playful routines. And when somebody is talking, the sensory motor cortex is active, the Broca's area is active, and as well it is connected to the frontal lobe. So the most important thing is communication and communication exchange. So don't have time to go more into those details. There are some families where there is loud talking. Arey bagunavra, arey rara niche. This is the tone of the voice I have seen, and I've seen this in daycares also. An infant from newborn time hearing those kind of loud noises, or hip hop, sorry, I don't want to be sued, Devi Prasad music, which is Shivamani drums and everything, all those are going to suppress hearing. They don't know how to close their ears and run away. They don't hear, and that will cause the baby not to connect to the world. Same thing with the touch. A depressed mother, postpartum depression, no matter what anybody says, some studies say 40%, but we see that 70%, because we always give PHQ-9 for the mother to fill it up. There is always like blues, postpartum blues, sudden hormonal changes and everything. And that makes a mother not interact with the eye connection, with the gentle touch. It feels like it's a burden to take care of the infant. We need to counsel the parents so that they prepare for the arrival of the newborn, prepare for what are the normal newborn behaviors and everything. And this is Kirshen's NIH study, where you have lifestyle management. When there are at-risk genes, they do not get expressed if the lifestyle management of removing the emotional stress, giving a good nutrition, and internal relaxation. Internal relaxation, now we are talking about mindfulness practices, pranayama. Our Sanatana Dharma is coming up. Our Ashtanga Yoga Sadhana is coming up. The Arya culture that Ramakrishna mission is doing, it's wonderful. They are making these mothers relax. They are having normal deliveries. They exercise. You won't release brain-derived neurotropic factors to the fetus if the mother doesn't exercise. And if she eats the wrong foods, it causes problems. So the EPO cells 1 and 2, they do not get genetic expression for neural migration, proliferation, transference. It's the same thing that I'm talking about. Come on. If there is methylation process at the histone tail, there is no expression of genetic expression of messenger RNA taking and impacting the DNA sequence. Whereas if it is acetylation process, there will be a genetic expression because messenger RNA breaks into the DNA sequencing. So we do not have to accept neurodiversity is genetic. Genes, I had many cases where mom and the kid had the same genes, microchromosome, microarray. Mom is fine, PhD scholar, and a nice study. And then there is a reference over there. This doctor has documented if there is emotional stress in the mother, there is a hippocampus shrinkage of the volume. Your hippocampus is amygdala and uncus for coordination and intellectual development as well as emotional control. There has been studies doing that. So we are able to do fetal scans now non-invasively and without any drilling sounds. And the fetus is connecting, and this lady did all the studies for each week of the pregnancy. By 28th week, based upon mother's emotions, based upon the mother's stories, based upon what the mother is hearing, if she's seeing all the lungi fights and getting hyped up with the bloodshed and guns and violence in the movies, that does affect the fetus, definitely affects the fetus. And there is an emotional strain. All the epigenetic studies have come from HPA axis, hypothalamic adrenal axis. And the mother's brain is tuned into, they won't let me use the scan, so we use the illustration. So mother's brain is tuned into in the nucleus accumbens, and we produce dopamine to give the compassionate care. But if there is depression, manic depression, and general anxiety disorder, that is missing, so that is going to cause relational problems in the parent, in the dyadic connectivity. So here we have opportunity to do anything in the pregnancy, prenatal period, going back to Garbha Samskar of Chandakya Upanishad, to happiness of the mother, eating right and everything, to the first 24 months. After that, you lose the plasticity, and the next slide will document that. And so I'm really trying to rush through that. Here, your opportunity of doing something so that the child is engaged in visual things ends by the 10th month. So an example is your lazy eye. If you don't detect it and you don't mask the normal eye, there is a total blindness, complete blindness, legal blindness. In the same way, if you do not have a newborn hearing screening, the child is not hearing and you have not done acoustic reflectometry, that child is vulnerable for lifelong inability to speak or perceive, use the Wernicke's and Broca's area. And that speech discrimination, if you teach 2 or 3 languages, one person speaking one language, the other person speaking other language, and I encourage a lot of our Indian population in USA to expose them to slokas and Vedas, because a lot of Sanskrit effect has been documented on the gray matter development in the prefrontal cortex by Ames and Hartzell at Harvard University. And so one person speaks one language, the other person speaks other language from birth, and the discrimination starts deteriorating between 5th month to 8th month. You cannot teach all the languages. Children who learn 3 or 4 languages, they're better cognitively, neurocognitively, they're better individuals. They are more intelligent than the others. And I have a tape I cannot show. Do these courses for 45 hours actually. So this is called experience expectant developmental opportunity, when wide windows of opportunity are open in the first 36 months of life. They start closing down. What happens is a rich, broad bands, if brain is a digital analog, and anything, the senses are the software. Those bands, rapid transmission, if you stimulate the eye movement, rapid transmission in hearing and perceiving and understanding, and that gets delayed if it is put off later on until the 3rd birthday or so. That is why UNICEF has this early child care and education concept. Experience dependent, you always connect the brain, but what happens in 7 days until that time takes about 6 months to 2 years. So we focus so much upon anthropometrics. How tall is your baby? Is he moving? Is he cruising? Is he walking? It's only gross motor and fine motor. But what is happening inside the brain is bottom up, is already closing after 12 months. So we are more dedicated to diagnose autism through early red flags. And that study has not been done. That's a wonderful study that could be done in a center like this that is just starting its footing. So there is a sensory development where immobile infants, where mother teaches the body parts, reads books, talks about colors. It is called thematic representation in the brain that happens in the first 0 to 6 months. After 6 months, they have cue, cause, and effect. It's a functional development. Through the play, through interaction, they can be taught numeracy, they can taught by quantity, they can know the numbers, and they can know spaces, organization, visual spatial reasoning, auditory spatial reasoning, everything is possible. And symbolic representation where they make association with what they hear, what they see, and try to implement, like a cardboard box here has become a rocket ship where they're watching through the telescope. And imitation and collaborative development starts between 24 to 36 months. And I think every adult has to keep this in mind because they imitate our words, our thoughts, our actions, because they're very intuitive and we need to motivate a better development. Everything is intertwined. If social emotional learning is compromised, they cannot be focusing in learning anything because they withdraw. And this is called freezing, dissociation, flight, freezing, hyperarousal, fight. And these are the two categories of 354 personalities we see. And the most important is social emotional learning that has warm, responsive care, developing attachments, emotional intelligence, emotional regulation. Pro-social behaviors, what we see in autism, are all happening before the child is 12 months old, before 6 months old. We're not catching it because we're not teaching the mother the importance of this, okay? And the linguistic abilities, communication, verbal, nonverbal, expressive language, and all those are because we are talking to them. It is mutual relationship. And cognitive development is the end result of better SEL as well as the linguistic abilities. Plasticity is lost after the 4th birthday. The pathways won't say, resilience will not be sustained, recidivism is high. And these are there in every society. The rooted is inequities, poverty, migrant labor population. But then there is so much of alcoholism at individual level that is causing problems and shoutings and, women is being compromised. I've been to Haiti, I've been to Guyana, I've seen in the Puttaparthi villages also. This drinking even among women is causing fetal alcohol syndromes in the infants. And we need to curb this. We need to curb this through awareness and education. And on top of that, crazy mothers, depressed mothers who are not interacting. We are hurting our children without knowing. And if a child is witnessing every day loud noises and shouting and coming as an alcoholic husband, which is the most common, it doesn't mean mom is not doing. In IT population, I've seen that also. There is no homeostasis. If you drink water, you have to pee. If you eat food, you have to go to the bathroom. If you breathe in, you have to exhale carbon dioxide. But if you breathe in through all the senses and adverse and toxic stress, if you don't get rid of that through awareness project, that will never come back to normal. This is hyperarousal dissociation and hyperarousal freezing, dissociation freezing. And as you know, the sympathetic nervous system causes Takatobi syndrome. Suddenly, teenagers drop dead because they're stressed out. Their heart has gone into myopathy. Their GI system is disturbed and they get gastric ulcers. Your gluconeogenesis from the stress and cortisol, not only is gram per gram is doing damage to the brain, but it is also causing gluconeogenesis and non-alcoholic fatty degeneration of the liver and diabetes, hypertension, enuresis and copresis, sexual dysfunction. But all can be mitigated through lifestyle management through Ashtanga Yoga Sadhana, mindful practices, pranayama, yoga. These can be taught from 18 months upwards. And there is a special classes we take on this one. And as Dalai Lama said, if every 8-year-old knew yoga sadhana, there won't be violence on earth. And who are the ones who we could be proud of creating a better world? Only the general pediatricians. We are 95% of the population, okay? Who can do 95% of the population? We don't have to be super specialists. And 0-3 should be a subspecialty that should be started in the clinics. So you specially train those people to handle and then go to general pediatrics. So remember, which brain do you want to create for your child who comes into your field? Brain on the left side, not on the right side, right? Neurodiversity. And this is a... Okay. Is it still there? Okay. This one you have to remember. This is about the wiring comparison that came out in 2016. Autism spectrum disorder with the controls. I don't have a cursor to show you, but if you see these, this is a normal. The right side of the brain, left side of the brain, within the brain they're red, that is connections. Whereas right on the top, they're disconnected. There is no connection between the genu and the splenium of the corpus callosum. Compared to the OCD that came later on, it's the same thing with autism spectrum disorder. ADHD is worse compared to the normal and the OCD. There is no connection within the brain. There is, I'm not used to that, I'm used to mouse. Okay, there is no connection at all within the brain. And within the right brain, and right brain connects to the world, to thoughts and rhythms and language and everything. Left brain does not, it takes all the information, long-term memory, peace and critical thinking. But both brains have some properties. But if your right brain is compromised, it's never connecting to the left brain. So when is the root for autism, neurodiversity, or any of the disorders? Even to have happy hormones. 0 to 2, the first 1,000 days. Why are we not paying attention to that time? Why are we not doing, thinking about creating a better individual? Because what you are in the future is related to this time right now. Same thing with a child who grew very happily. Here is the prefrontal cortex. Video gaming, which is an addiction, which is very difficult to treat, and 3 hours a week, it became a prune of a brain. There is dopamine depletion that has happened. No positive reward system sensitizes them, and prune of a brain. There are 14 neuropsychiatric conditions. First, motivation is lost, then memory is lost, then focus attention is lost, then there is depression, anxiety, going for the same gaming again. Why? When you're gaming, your cortisols are high. And this can happen at any age, and we are dealing with internet addiction, making people withdraw from the schools. And so there is an overlap in the neurodiversity. I have to keep moving. We have to catch the signs before 12 months, ideally before 6 months. Is there an eye contact? Is the child is listening, not just hearing? And you cannot put a music somewhere there and say, child, here. There are Bayesian principles. I cannot go into those, but there's a special class by itself. And if you miss that, and if you catch atypical child development before 6 months to 12 months to 18 months, intercept ECI, early child intervention. If you miss, even then, you need the cognitive behavior modification therapy, trauma-focused, or ABA therapies and everything. It's so expensive. 1 lakh rupees for one session of PT, OT, ST, ABA. I know that. And no, it's unaffordable. Every baby can do this one. So her mother is holding a camera. She didn't tell her, it's a 4.5-month-old. She said, clap, baby. And she's clapping on the thigh. She said, can you clap with both hands? She did that. What made the child know what clap is? Both hands, everything, because mother interacted with her. And she's so happy. Oh, this one I want to play. Where is the volume for this one, guys? It's not coming. I don't know if I have time, to show this. Okay, this is a still face experiment.
We set up a situation where we were looking at face-to-face.
Are you able to hear?
Mothers and infants. We film those, and we would code the baby's facial expressions and the mother's facial expressions.
So this is about a facial expression when we do not interact with the child, how the child withdraws, tries to get your attention, and if you still not pay attention, there is no synchrony. That child withdraws totally. So that's the experiment they're showing. This one is not. Sorry, I can.
Stop the presentation and reshare. You can.
No. So just watch it. See the child coughing. The child is looking at the mother who is not looking at her. And this is happening, guys. This is happening so much that we have to control this. She's happy when the mother is interacting. So they ask the mother to keep a still face. First, she tries to kick her legs, then her arms, then she's a little bit forced to cry, then she will cough. You cannot hear that now. He said, I have to stop my presentation to do that. She's coughing. Try to get the attention. Kids cry. Why do kids cry? It's a communication. I need you. I want you. Do something for me. And what I have seen is, I've seen this in the malls. They go with the leash and the child will be pulling mommy's pallu, trying to get attention. They hit them. Instead of, going to their eye level and say, what do you want? I don't know what is happening. It doesn't take much. It is not money, right? So she's happy again. So, sorry. What is happening here? This baby is crying away. Either she lost a job or a COVID or lost a person, boyfriend broke up. And that baby immediately withdraws repetitiously if it is done every single day when the baby is not crying. But if the same mom comes back and can give a warm hug, that's called synchrony. Etronic described that one. That is not happening here. So we are caught up in our own life. And if two people are working, the kid is being watched by a nanny who doesn't have any patience, and that kid is exposed to a tablet and iPhones. And look at the expression of this infant who is neglected. So we are bringing evidence-based data. I have lots of references that Afreen has, if you want to take. But we need to change the way we are educating our pediatricians. We need to change the way we are talking to the pregnant ladies. I don't want us to put down our Chandogya Upanishads, Garbha Samskar. Everything is directed towards eating right, being happy, and listening to classical music versus filmy music and filming sound. That is going to affect the volume of the brain. I have all these things, but we need to be educated. You need to be educated 0 to 3 SEL, and CD as a separate entity, and bring this one and take it to ASHA workers and the community things. There has to be intention. There has to be, who is learning? The child is already learned. They have implicit capabilities. We need to support and foster and teach those competencies and provide a ground for their exploration and expansion. Their mirror cells start copying us from birth. There is so much more. A child standing alone like this palm tree cannot grow. And here is the last story, thanking Gymkhana organization Dr. Lal, CME event coordinators, everybody giving me this opportunity to stand here. But I came with so much of enthusiasm that we need to start something different for mother-child unit facility with the modern neuroplasticity as an underscoring subject that we need to really do extra. You are welcome to go and visit my mychild-educator.com. And I take a lot of pleasure in doing this, and I give sessions, I do echo sessions. So how about this little story about this Foxy Woxy walking away being, I am the proud person, I can do anything. Goes to a rabbit, and rabbit feels so threatened and said, of course you are the great boss. He walks proudly and feeds Little Red Robin Hood, who is intelligent enough to tell him, yes, you are the greatest on earth. And then he walks with more pride, but he goes to this little dragon and says, who is the greatest? I said, of course, my mom. And then he shouts and he threatens. That resilient, self-confident, and reliable on her family, that dragon says, of course, my mom. And he looks up and there is a mom as a base supporting this child. That is our family unit. That is our community. That is our empowerment we lost altogether. I can go on like this. I have so many. The risk factor times vulnerability by accountability. If we are responsible for this, we do not have a boundary violation of losing our tempers with a catalyst. Risk factors are usually underlying either having seizures, schizophrenia, or another child having autism spectrum disorder, or mental health disabilities in the family. And vulnerability is your inequities, illiteracy and your poverty. But then if there is somebody who is accountable for them to be overcome, we don't see that boundary violation to be to the cross, to the square root. Okay? And the catalyst should not move it. So we are everything. I have many videos. I'll just leave it that. Thank you for this opportunity, Gymkhana. Thank you for this opportunity. This is Ardhanariswara Tattvam here. I am not from Gymkhana. I am from Gandhi. But my husband, my spouse, half-life, is from Gymkhana, Dr. Kedar Chintapalli. So I'm happy. I hope everybody will think through what I presented. It is just 10% of what I could do. Thank you. Questions? Challenges? This person had 46 years of implementing neuroplasticity. It all came in 79 when I was a fellow at University of Michigan, when I saw psychosocial dwarfism, a 3-year-old, 18-month-old, and bone age of 15-month-old, who had a global developmental delay, food hoarding, and he wasn't really paying attention to anything going around him. But when it is called psychosocial dwarfism, well described, high alert, HPA axis overdrive. When he was placed in a nurturing home, he grew 2 inches. And why there was neuroendocrine suppression, why there was global delay was my question. And I developed protocols. I followed through for any condition, even headaches in teenagers. What happened? What happened in your early life gives you a lot of answers. Okay? Anybody can challenge me.
They don't have any. Okay.
No questions?
Okay.
It is outside your field, right? It's not your field.
So, thank you so much, Dr. Chintapalli. Sunil, do we have any questions online? Okay, could we switch to this one? You can take it. Can you hear me? Yeah, you can take that. So, okay, let them take the picture and then we can go for the last speaker of the evening. Afreen, is speaker ready? Did she join? Wonderful. Yeah. Yeah, I can see Dr. Padmavati Patel, but she's not on the camera. Yeah, I can see her. Hi, Dr. Patel.
Hello.
Okay, so Dr. Patel is the last speaker of the evening, and I have one last announcement. Again, if you guys need the CME, these QR codes are around the auditorium. Please go ahead and scan the QR code, and then you can get the CME certificate. And also, Dr. Chintapalli, she has so much information, so we are planning to produce a series, webinar series with her. I mean, we didn't had that plan before. After listening to her, after seeing her passion, our company, eMed Events, we have decided to produce the webinar series. So let's go for the last speaker of the evening, Dr. Padmavati Patel. She's a board-certified anesthesiologist serving Detroit Medical Center under an John D. Digo VA Medical Center. She's a clinical assistant professor at the Wayne State University and is actively involved in the resident and medical student education with expertise in perioperative care and anesthesia quality improvement. Sorry about that. So let's welcome our last speaker of the evening, Dr. Patel. The stage is yours.
Thank you. Good afternoon. My topic for this evening is caring for mothers at the strongest moment, the vital role of obstetric anesthesia. I don't have anything to disclose. So the objectives for my we discuss about the evidence-based principles of obstetric anesthesia practice, anesthesia management for both routine and high-risk obstetric patients, major contributors for maternal morbidity and mortality, and strategies for prevention. And then I would like to highlight the role of obstetric anesthesiologist in improving maternal outcomes. The goal of labor anesthesia is the delivery of the infant into the arms of a conscious and a pain-free mother is one of the most exciting and rewarding moments in the medicine. So pregnancy represents a unique and a high-risk physiological state with a limited reserve. So obstetric patients can rapidly transition from a stable to a critically ill situations. Obstetric anesthesiologists serve as a team leader during the emergencies. So our role directly impacts maternal safety, neonatal outcomes, and system-based care. Let's talk about few physiological changes in pregnancy. Pregnancy causes predictable physiological changes that affect anesthetic management. So these changes involve the cardiovascular, respiratory, gastrointestinal, and neurological systems. Understanding these adaptations is essential for safe anesthetic care during the labor and delivery. Let's briefly talk about the highlights of the cardiovascular and respiratory changes. Blood volume increases by 40% and cardiac output increases to 50% by mid-pregnancy. Systemic vascular resistance decreases so as the blood pressure decreases. This leads to altering blood pressure responses to anesthesia. Iotocaval compression can reduce venous return in supine position, so we got to be careful asking the posturant to be on a left lateral position after 20 weeks of gestation. Functional residual capacity decreased due to cephaloid displacement of the uterus and then the diaphragmatic elevation. While oxygen consumption increases by 20 to 30%, these leads to increasing hypoxic risk. PaCO2 decreases by 30 millimeters of mercury during pregnancy. We also notice dilutional anemia, hypercoagulable state, during pregnancy. And also increase in insulin resistance, increase in cortisol, progesterone, and estrogen levels during pregnancy. Pregnancy-related airway edema increase the risk of difficult intubation, gastroesophageal reflux, delayed gastric emptying due to lower gastroesophageal sphincter tone. These increases the risk of aspiration. Minimum alveolar concentration for volatile anesthetic is reduced by 30% during pregnancy. Changes in drug distribution and placental transfer affect the anesthetic dosing. During pregnancy, we notice increase in plasma volume and total body water. This leads to increase in volume of distribution for hydrophilic medications like neuromuscular blocking drugs. And also decrease in plasma albumin leads to increase in free fraction of highly protein-bound drugs like local anesthetics, benzodiazepines, and opioids. We notice increase in epidural venous engorgement during pregnancy, which leads to decrease in epidural and intrathecal space. So the dose to be decreased about 20 to 30%. Otherwise, we may see high levels of blockage. Practice guidelines for obstetric anesthesia published by American Society of Anesthesiologists provide evidence-based standards for obstetric care. And the Society of Obstetric Anesthesia and Perinatal Guide best practices for safety and quality. These guidelines emphasize timely neuraxial access, that means epidurals, and appropriate staffing, equipment, and emergency preparedness is very important. Let's talk briefly about the maternal mortality. According to statistics in 2022, about 260,000 maternal deaths worldwide, 197 maternal deaths per 100,000 live births. In US, it is about 18 per 100,000, and in India, it is about 103 to 80 per 100,000 live births. Unfortunately, India is the second highest in worldwide after Nigeria, around 52 maternal deaths per day. 712 maternal deaths per day worldwide. Over 90% maternal deaths occur in low middle income countries. Significant racial and socio-economical disparities present, but many maternal deaths are considered preventable. Anesthesia and other specialties like cardiology, endocrinology, neonatology involvement is crucial in the prevention efforts of these maternal mortality. Antenatal and preoperative assessment is very important that an early anesthesia consultation allows identification of high-risk obstetric patients. A thorough evaluation includes medical history, airway assessment, and neuroaxial considerations regarding risk and benefits of epidural and spinal anesthesia. Multidisciplinary planning improves communication and reduces the peripartum complications, especially in high-risk patient population. Clear documentation ensures continuity of care across the teams. Let's talk about a case scenario. With this case scenario, we can talk about epidural anesthesia, general anesthesia, and spinal anesthesia for C-section. We have a patient, 39-year-old woman, gravida 1, para 0, at 29 weeks gestation, was admitted to the hospital because of elevated blood pressure, 182 over 111 millimeters of mercury, with a headache and also a proteinuria. So the classification of hypertensive disorders in pregnancy are gestational hypertension. That means new onset increase in blood pressure after 20 weeks of gestation. Preeclampsia is a hypertension after 20 weeks of gestation with proteinuria or any other end organ dysfunctions. Preeclampsia may be with symptoms, without severe symptoms. Chronic hypertension preceding pregnancy, that means hypertension even before 20 weeks of gestation. Hypertension with superimposed preeclampsia is a chronic hypertension with preeclampsia conditions. So then what is preeclampsia? It is a multi-organ disease with hypertension, along with proteinuria and end organ dysfunction after 20 weeks of gestation. This affects about 2 to 8% of all pregnancies worldwide. Most common, we see it in the first pregnancy. Preeclampsia is a leading cause of maternal and perinatal morbidity and mortality worldwide, especially in developing countries. Around 30% of women aged 15 to 49 years have increased blood pressure or on medication in Andhra Pradesh. Preeclampsia prevalence in Andhra Pradesh is about 3 to 8% among the pregnant women. Maternal mortality is about 1 to 3% with preeclampsia, and then the recurrent risk for future pregnancies with preeclampsia is about 5 to 25%. So there are three components for preeclampsia: hypertension, proteinuria, and end organ dysfunction. So what is hypertension? Any blood pressure systole of 140, diastole of 190 millimeters of mercury on 2 occasions, or at least 4 hours apart in a previously normotensive patient, or any single reading of 160 over 110 is defined as hypertension. Proteinuria, usually about 300 milligrams of protein in 24 hours urine and a positive urine in the urine dipstick test. End organ dysfunctions may range from thrombocytopenia, elevated liver transaminases, pulmonary edema, new onset of cerebral or a visual disturbances. Let's talk about HELP syndrome. What is HELP syndrome? H stands for hemolysis, EL for elevated liver enzymes like AST, ALT, about 2 times the normal range, and LDH about 600 international units per liter, and then the low platelet counts. This HELP syndrome is a severe life-threatening variant of preeclampsia seen in pregnancy, often in the 3rd trimester or during postpartum period. Most commonly seen in multiparity, advanced maternal age with diabetes and chronic hypertension. Let's talk about few alterations in preeclampsia, like a cardiovascular system, increase in blood pressure due to increase in peripheral vascular resistance due to sympathetic overactivity, and then hemodynamic changes like a hyperdynamic condition due to increase in cardiac output, hypercoagulable state, thrombocytopenia, and proteinuria. And there is a breakdown of normal balance between vasodilators and vasoconstrictors during a preeclampsia. There is a laryngeal edema, which may lead to a difficult intubation if we have to go for a general anesthesia. As I mentioned earlier, there will be increase in liver enzymes, neurologically severe headache, visual disturbances, and then the occurrence of seizures indicate eclampsia until proven otherwise. There will be uteroplacental perfusion decreases that leads to intrauterine growth retardation. These are some of the important things we need to think about it when there is a patient with preeclampsia. What are the complications of preeclampsia? Maternal complications are DIC, congestive heart failure with the pulmonary edema, placental abruption, postpartum hemorrhage, liver rupture, cardiovascular accidents. Leading cause of maternal death is intracranial hemorrhage. Fetal complications are prematurity with respiratory distress, intrauterine growth retardation, and then small for gestational is aspiration meconium. The leading cause is intrauterine morbidity, mortality due to uteroplacental insufficiency by placental infarct or placental abruption, chorioamnionitis. Preoperative evaluation and preparation includes labs like a hemoglobin, platelet counts, coagulation profile, serum electrolytes, and then urine for protein. Type and screen is very important for all the posturants before going for a labor. If there is any antibodies present, then we got to get the cross match also before a C-section or a normal delivery. Is there a special platelet count that predicts the risk of complications from regional anesthesia? Really not. But the trend in platelet counts is important because preeclampsia is a dynamic disorder and a rapid decrease in platelet count in a shorter interval may warrant the concern. So then what is our cutoff for platelets? Patients must be individualized and a thorough bleeding history. Trend in platelet count should be always considered. If there is a platelet count of less than 100,000, serial platelet counts, PT, PTT, and fibrinogen levels should be measured. So what are the common monitors we need to have it when the patient is preeclamptic or in general normal delivery patients? Is standard ASA monitors, but patient is getting an epidural, then we'll put a Foley catheter. Patient has preeclampsia, we need to monitor for deep tendon reflexes, tochodinometry, A-line and a central line, very important if the patient conditions are not stable with hemodynamical instability, especially in eclampsia, preeclampsia, any cardiac cases. Coming to the obstetric management, the goal of therapy is to stabilize the mother and to safely deliver the fetus and placenta. For normal healthy patients, in United States, we provide 90% of the patient populations get an epidural once the 2-centimeter dilatation of the cervix. And other 10% of the population, they will choose normal methods of delivery. But in this case scenario, we talked about it. So patient is hypertensive, so antihypertension medications needs to be started, and then to prevent the stroke, MI, and the cardiac failure. Prophylactic seizure medications like max sulfate. And then now it is very important to determine the timing of the delivery. And also we need to involve multidisciplinary meeting and planning when to deliver the baby with the neonatologist, anesthesiologist, and then OBGYN. For example, if the gestational age is more than 37 weeks without any severe features, we can deliver the baby. If it is less than 37 weeks, and we need to closely monitor, but if the severe features are end organ involvement, HELLP syndrome, pulmonary edema, then if it is more than 34 weeks, deliver after the maternal stabilization. If it is less than 34 weeks, expectant management if maternal and fetal condition is stable. Start giving antenatal steroids. Either you can give betamethasone or a dexamethasone. And immediate delivery at any gestational age, if there is an eclampsia, uncontrolled hypertension, HELLP syndrome, any placental abruption, non-reassuring fetal heart status. Let's talk briefly about the eclampsia. A new onset generalized tonic-clonic seizure in a preeclamptic patient is called eclampsia. So we need to control the blood pressure in this patient population with lobetalol, hydralazine, nifedipine, or esmolol. The target blood pressure is systolic blood pressure less than 160, diastolic blood pressure less than 110. Max sulfate can be started with a loading dose of 4 to 6 milligrams over 15 minutes, and then maintenance with 1 to 2 grams per hour. And we need to monitor for toxicity like a loss of deep tendon reflexes, respiratory rate less than 12, urine output less than 25 ml per hour, any EKG changes. If there is any toxicity noticed, then the treatment for that max sulfate toxicity is calcium gluconate 1 gram. So then what is our choice of labor analgesia? Most anesthesiologists and obstetricians consider epidural anesthesia the safe and the preferred form of pain relief for labor and delivery in preeclampsia patients or any other general healthy patient. Epidural anesthesia provides a superior pain relief compared to other analgesic methods. It attenuates exaggerated hypertensive response to pain. decrease in circulating levels of catecholamines and stress-related hormones, improves the intravillous blood flow, stable cardiac output. But there are other options if the patients are not going for an epidural. In US, they'll give Nubane. The generic name is nalbuphine, which is a mixed opioid agonist and antagonist. It is a systemic analgesia for obstetric patients, moderate analgesia with a ceiling effect on respiratory depression, making it a very relevant, relatively stable medication during delivery. Dosing is usually 5 to 10 milligrams, either IV or IM, with a rapid onset, and then it lasts for 3 to 4 hours. It crosses the placenta, but less neonatal respiratory depression. So during labor and delivery, we need to have a sensory level blockade of first says T10 to L1, and then the second stage labor, S2 to S4. Local anesthetics for labor analgesia, most common drugs we use are bupivacaine and lidocaine, 2-chlorprocaine. Bupivacaine is 4 times more potent than lidocaine, but it is more cardiotoxic. Ropivacaine is a homologous of mipivacaine and bupivacaine, but it is a less cardiotoxic. Chlorprocaine is a ester type of local anesthetics and hydrolyzed by the plasma cholinesterase, and then it is very quick onset. Usually we use this one when the patient already have an epidural going for a stat C-section, then we will top up with 2% chlorprocaine, 1.5 to 2 milligrams per kg, and then it gives a sensory block up to T4 level, and the duration of action will be 30 to 60 minutes, and we can, because it's an epidural, we can top up with another 5 cc's of chlorprocaine to continue the C-section. But if the patient is having a normal epidural, the concentration what we use are bupivacaine 0.0625% to 0.125% bupivacaine. And along with that, we can add like a 5 mics per ml fentanyl. We'll start with a bolus of 10 ml and then infusion at 8 to 12 ml per hour, depending upon the patient conditions and then their comfort level. Sometimes we notice abnormal fetal heart rate pattern after the epidural analgesia. It is because of a sympathetic blockade, which leads to decrease in the systemic vascular resistance. That leads to decrease in uteroplacental perfusion. And then this effect is due to maternal hypotension due to epidural analgesia. Then we notice late decelerations and decreased variability of fetal heart rate. But this is only a temporary and a reversible side effect. Then we can administer oxygen to the mother, left uterine displacement, IV fluid bolus, maybe 500 or 1 liter, ringer lactate or normal saline. If in severe cases, you can elevate the lower extremity to improve the venous return. But if there is any decrease in blood pressure more than 20% of the baseline, then we can give small doses of phenylephrine, 50 to 100 mics, and ephedrine about 5 to 10 milligrams. What if there is an accidental dural puncture? What happens? And then we have a couple of options for that. We can remove the epidural needle and then reattempt another interspace if the patient is looks normal, and then if you can able to get it. Other option is catheter can be threaded into the intrathecal space as a continuous spinal labor analgesia. It is more preferable if it is a very difficult epidural obese patient, then we usually proceed with the spinal labor analgesia. But the concentration we got to use is 1/3 dose of the epidural solution. And then you can secure it carefully and then tape it. Mention that is a spinal labor analgesia, not the epidural. In that way, if anybody comes there, we don't want to increase accidentally the rate into a higher concentration just as a regular lumbar epidural. Incidence of post-dural puncture headache after the accidental wet tap with epidural needle is more than 50%. So headache occurs within 24 to 72 hours of dural puncture, and the symptoms like worst headache ever. And then it is very positional, and it's most common when the patient is sitting up and standing, and it is relieved on lying down flat. This is a very key diagnostic feature. Other signs and symptoms like nausea, vomiting, tinnitus, blurring of vision, and neck pain. Effective treatment is mostly, we will start with the medical management, IV fluids, and any caffeinated beverages like a Mountain Dew, Coke, or something like that. And then we can give Motrin, Tylenol. And then also patient can get oral or IV caffeine that helps the patient headache most of the time. But if it is not relieved by medical management, the gold standard of treatment is the pain right away with first attempt. So let's talk briefly about the total spinal anesthesia. A high spinal anesthesia may occur several minutes after epidural injection of local anesthetic, especially if the injection is into subarachnoid or a subdural space. It is important to communicate with the patient because the patient may get agitated, dyspnea, difficulty speaking, may indicate the onset of total spinal, and they can't feel their hands. The level will be all the way to cervical level. So avoid the iotocaval compression, give 100% oxygen. If the patient is really becoming hypotensive, can't breathe, then we got to rush for a C-section. In that situation, we can secure the airway with the ET tube. Monitor continuously the blood pressure, EKG, and then the fetal heart monitoring, and the support maternal circulation with IV fluids, vasopressors, neosynephrine, ephedrine. If needed, the patient may need sometimes epinephrine also when it is a total spinal. Let's talk about the C-sections. How about spinal anesthesia? Spinal anesthesia may be useful for cesarean delivery with preeclampsia. The concentration what we use is a hyperbaric bupivacaine 0.75% with or without fentanyl or a duramorphone. If the fentanyl or duramorphone gives synergistically very solid block and then prolonged block after the C-section also. Advantages are avoidance of general anesthesia and then eliminates the risk of a hypertensive response during intubation. And it is more reliable anesthesia than epidural because spinal anesthesia gives a very good motor block. And the needle used is very small compared to epidural needle. So there is a less trauma to the epidural veins. General anesthesia for a C-section, what are the preparations? Aspiration prophylaxis. We can give Bicitra, Zantac, metoclopramide. A-line before induction in unstable patients, especially with preeclampsia, with a severe hypertension. Any cardiac patient is having a C-section. If there is an anticipated difficult intubation, have a glide scope ready, pre-oxygenate the patient. Induction with cricoid pressure, either with propofol or etamidate, depending upon the vital signs. Succinylcholine for rapid sequence intubation. And then smaller ET tubes are preferable because of airway edema. And then max sulfate can be continued intraoperatively and postoperatively if the patient is preeclamptic. Administration of volatile anesthetics until the delivery is to prevent the awareness under anesthesia. Once a baby delivered, we can decrease the volatile anesthetic concentration to 0.5 MAC and then add some nitrous. In that way, we can decrease the uterine atony and the bleeding. Preferably the elective C-sections, the skin incision to the baby out within 3 to 5 minutes. For emergency C-sections, it has to be under 3 minutes. Postoperative management, provide adequate analgesia with multimodal pain control with acetaminophen and NSAID, mostly with non-steroidal anti-inflammatory medications. Avoid narcotics if possible. Regional anesthesia is preferable, like epidurals. And if a patient needs a spinal anesthesia, add narcotics into that one. It will give you more pain control after the delivery. If the patient goes for a general anesthesia, then we are providing a tab blocks, which is called a transverse abdominis plane block with the bupivacaine, which gives pain control for 24 to 48 hours. But now we are using Exparel, which is a liposomal bupivacaine, it will give a pain control up to 72 to 90 hours. Continue the max sulfate for 24 hours after the delivery and maintain strict intake and output. Maintain hemodynamic control with antihypertensive medications if needed. Continuous monitoring for especially preeclampsia and eclamptic patients for the stroke and pulmonary edema in the postpartum period. Enhance recovery after the cesarean delivery. Enhanced recovery protocols improve the maternal outcomes following a cesarean delivery by pre-procedural counseling and expectation setting for the posturants before the plan for a C-section. Neuraxial anesthesia with the intrathecal opioids forms the foundation of analgesia. Multimodal non-opioid analgesics reduce the opioid consumption. Early mobilization, like 6 to 8 hours after the C-section, and feeding promotes the faster recovery and a shorter hospital stay. DVT prophylaxis from the beginning of C-section, antibiotics within 60 minutes of the incision, aspiration prophylaxis. Avoid prolonged fasting, and then shorten the solids for 8 to 6 hours, and then the clear liquids up to 2 hours before the C-section. And remove the Foley catheter within 6 to 12 hours. Optimize comorbidities like anemia, hypertension, diabetes. These are the protocols for us, even in the ERAS protocols for C-section and any other major surgical procedures nowadays. Let's briefly talk about the other risk factors in pregnancy, like gestational diabetes. About 14% of pregnant women worldwide are affected by gestational diabetes due to increase in obesity, advanced maternal age, and a family history of diabetes mellitus type 2. Gestational diabetes affects glucose metabolism during pregnancy. Peripartum glucose control reduces the maternal and neonatal complications by having a target fasting blood sugar levels at 95 milligrams per deciliter. First hour postprandial like 140, and then the second hour postprandial like 120. Neonatal hypoglycemia is a key concern. Coming to the anesthesia management, labor anesthesia, we can do spinal anesthesia or epidural anesthesia. Generally is preferable if there is any anticipated difficult airway, macrosomia, or a shoulder dystocia. Endocrine consultation is very important the patients with the gestational diabetes, because there is a risk of about 50% they may develop in future a diabetes mellitus. So other obstetric conditions affecting the anesthesia care are placental abnormalities, increases the risk of hemorrhage. Postpartum hemorrhage remains the leading cause of maternal morbidity and mortality, about 5 to 10%. Early recognition and the preparation are essential for safe anesthesia management with multidisciplinary meeting, especially with the blood bank team, because anticipated major blood loss in these cases. Regional anesthesia is okay with a stable previa, but if it is accreta or unstable abruption, it is preferred for general anesthesia. Anesthesia team plays a central role in massive transfusion protocols. Pregnancy and heart diseases. Cardiac diseases complicate about 1 to 4% of pregnant women globally, about 15 to 20% of maternal mortality due to heart diseases. Pregnancy places a significant physiological stress on the cardiovascular system. Conditions like valvular disease, cardiomyopathy, and congenital heart diseases are most common. Early identification improves the outcome, and the goal is to review the echo before labor, optimize volume status, avoid fluid overload, and maintain preload is very important. If possible, avoid spinal anesthesia, especially patients with the mitral and aortic stenosis. Avoid hypoxia, hypercarbia, tachycardia. Neuraxial anesthesia can reduce pain-related sympathetic activation. So preferably these patients will get epidural with low concentration. In that way, they can have a good pain control during a normal delivery. Postpartum it is preferable to keep the patient in ICU for 24 to 72 hours for monitoring. Let's briefly talk about the amniotic fluid embolism. About 1 in 20,000 to 40,000 deliveries, we come across amniotic fluid embolism. Maternal mortality rate is about 20 to 40%. Actually, it is not a true embolism. It is an anaphylactoid reaction. Entry of amniotic fluid, a fetal antigen into the maternal circulation, which triggers pulmonary vasoconstriction that leads to right ventricular failure and then eventually left ventricular failure, leads to DIC, decrease in fibrinogen levels, increase in PT, PTT, INR, thrombocytopenia, and then a massive bleeding. Amniotic fluid embolism is a very rare but catastrophic obstetric emergency. It presents with sudden hypoxia, hypotension, and coagulopathy. Diagnosis is clinical and one of an exclusion. Immediate support to care is very crucial. Provide 100% oxygen, secure airway to correct the hypoxia, hypercarbia, and correct the coagulopathy. And follow the massive transfusion protocol. And this patient population also needs ICU observation for potential pulmonary edema, ARDS due to massive transfusion, renal failure. Most commonly, this type of event happens in advanced age parturients, multiparous, placenta previa, abruption, most of the operative deliveries, rupture of the uterus. About 0.1 to 0.3% of pregnant patients may develop sepsis. Maternal sepsis contributes about 10 to 15% of maternal mortality rate globally. It is higher in low middle income countries due to limited access to the antenatal care, delayed recognition of the problems, poor sanitation, limited ICU and blood bank services, and unsafe abortions. Sometimes the physiological changes may mask early signs of sepsis. So prompt recognition and early antibiotics may improve the survival. Most common sepsis due to chorioamnitis, endometritis, retained products, placental abruption with infection, UTI, pneumonia, group A step. Hemodynamic resuscitation must balance maternal and fetal needs. And then the anesthesia management for labor, depending upon the patient conditions, hemodynamical stability, we can go with the epidural or general anesthesia. Substance abuse disorders in pregnancy, most common substance abuse with alcohol, tobacco, marijuana, opioids like heroin. These patients, most of the time, they will be on a maintenance therapy that should be continued during labor and delivery, especially they're on methadone, buprenorphine, Suboxone. We need to continue those medications. Compassionate, non-judgmental care improves the outcomes. These patients often require higher doses of analgesia, and maternal and fetal risk factors like preterm labor, placental abruption, low birth weight, respiratory depression, and low Apgar scores for the fetal. How do we prevent maternal mortality? By standardized protocols, they improve consistency of the care for conditions like hypertension, preeclampsia, hemorrhage, sepsis, anemia, and diabetes. Early warning systems facilitate timely intervention by identifying high-risk patients, optimized by early antenatal care, educate for recognition of early signs for bleeding, headache, visual changes, fever, decrease in fetal movement. Simulation training enhances team performance during crisis. It is one of the best teaching tools. Let's talk about the non-obstetric surgery during pregnancy. About 1 to 2% of pregnancies require non-obstetric surgeries like appendectomy, gallbladder surgeries, a kidney stone, something like that. Timing and anesthesia choice affect maternal and fetal outcomes. Do not delay urgent or emergent surgery because of pregnancy. Second trimester is preferred for elective cases, but avoid hypoxia, hypotension, acidosis is very crucial. No anesthetic agent proven teratogenic at the clinical doses. Left uterine displacement after 20 weeks of pregnancy is very important.
Recording in progress.
Okay. You're on the mute.
Dr. Patel, you have last 5 minutes which you need to complete or conclude. So, can you please?
Okay, got it. Dr. Patel, could you please conclude because we lost the power in the last 5 minutes? Not 5 minutes, just let's stay, like takeaways, your last slide. If you can repeat it, that would be great. Yeah, audience, I think I see that lots of medical students here. She's going to conclude. Just bear with us. We lost the power, as you guys know. Yeah, please go ahead. Last takeaway slide. Yeah, that
You want to talk
takeaways.
about the, no, okay. Yeah, I'll talk from here. Is that okay?
Sure, please go ahead. We have few
Yeah, I'll talk about this one because we already mentioned about the pregnancy-related concerns, but I just want to bring to your attention non-obstetric surgery during pregnancy. It is about 1 to 2% of pregnancies require non-obstetric surgeries like appendectomy and a gallbladder. So when you have a pregnant patient coming for a non-obstetric surgery, then how we plan it. Timing and anesthesia choice affects the maternal and fetal outcomes. Do not delay any urgent and emergent surgery because of pregnancy. If the patient can wait for a gallbladder surgery, we can preferably do it on the second trimester. But if it is an appendectomy acute, you got to go, we can go. But during anesthesia, avoid hypoxia, hypotension, and acidosis. No anesthetic agent proven teratogenic when you use in a clinical doses. Always use the left uterine tilt after the 20 weeks of gestation. So we need to determine a gestational age and fetal viability before we put patient under anesthesia for a non-obstetric surgeries. Aspiration prophylaxis. And then anesthesia is mostly preferable regional anesthesia, either spinal, if the patient is having an appendectomy, but we have to, if it's a urology, like a stent placement, we can do a spinal anesthesia. But if it is gallbladder surgery or obstruction, then we have to go with the general anesthesia. In that case, we have to maintain normoxia, normocapnia, normotension. Avoid iotocaval compression, so put the left uterine tilt, a wedge. And fetal monitoring is very important. We need to have a Doppler with the obstetric specialty. The physician can be there, and then they can monitor the fetal heart rate. if the gestation age is less than 24, they can monitor before the surgery and after the surgery. But if it is more than 24 weeks pregnancy, then if there is a possibility, we can continue continuously intraoperative period. Otherwise, we can monitor before surgery and after the surgery. And then post-operative management, use multimodal, like a non-steroid anti-inflammatory drugs, acetaminophen, and then mostly go with the opioid-sparing drugs. And then we can, if it is a general anesthesia, we can do a tab block. As I mentioned earlier, it is transverse abdominal spleen block. We can use bupivacaine. It will give you a pain relief for 24 to 48 hours. We can use some Decadron 5 milligrams to the bupivacaine. It extends the pain control for 48 hours. And also it is very important to monitor for preterm labor for 24 to 48 hours after the surgical procedures. So obstetric anesthesiology extends beyond anesthesia and analgesia. When done well, obstetric anesthesia is invisible. When needed, it becomes life-saving far beyond the pain control. So we need to establish quality improvement and a systems-based practice with OB and anesthesia teams collaboratively to provide better outcomes. Preparation and anticipation prevents catastrophic outcomes. So whenever there is a complex patient, it is a good idea to have a multi-specialty discussion before labor. In that way, we can provide a better outcomes. My closing message is caring for mothers at their strongest requires readiness for their most vulnerable moments. Obstetric anesthesiology stands at the center of that responsibility when things goes wrong. And these are my references.
Yeah. You got it. Thank you so much, Dr. Patel. I mean, you are awake in the middle of the night and you did it for Gymkhana. Really, it's really commendable. Thanks for your commitment for this. So, Dr. Lal, do you have any comments for Dr. Patel or, you know? Yeah, on behalf of your college, you guys can conclude.
Doctor.
Oh, she has a, oh, you're putting her in the spot, I think.
Dr. Lal.
You know, your classmates are here, Dr. Patel. That's what the excitement is here. So the camera, could you put the camera on her so that Dr. Patel can see her?
Yeah, I will introduce.
There you go. Can you see her?
Hey Padma,
Yes.
so
Hi,
good to
hi,
see you. I'm
hi,
very
Indra.
excited to hear his lecture from you. Yes, you have extensively covered not just anesthesia part, you have also covered the obstetric part quite extensively. I'm so happy to hear your lecture. I don't have any questions for you, but here is our Vijaya.
Hi, Padma.
Hi, Vijaya.
Hi, Padma.
Hi.
This is Dr. Sridevi. You said, I have one doubt. You said you give obstetric and epidural analgesia at 2 centimeters dilatation. Most of the times, 2 centimeters is not active labor. Now, according to WHO, it's 5 centimeters active labor. Previously, it used to be 3, then 4, now 5. Now, so what's your take on that?
When the patients are already here admitted in our labor, and then one of the literature says when the patient is asking for it, they're in labor, we can just go ahead, give the epidural, but we'll start very low dose. In that way, it is not going to obstruct anything. Usually when they come in, then we will put one in, especially some patients with obesity, diabetes, heart diseases, we just place an epidural in that way. When there is things goes down, like a suddenly patient, the maternal condition changes or a fetal condition changes, we have an epidural in place, we can proceed with the C-section.
Yeah, you're more comfortable. So it depends
Yes.
on the patient tolerance. Whenever the patient
Yes.
asks it, you give it. Okay.
Yes. And then we don't run a high concentration, it will be very low concentration.
Hi, Padma. This is Lal. For fantastic presentation.
Yeah.
Thanks for staying up through the night. I have one quick question. Pregnant moms with diabetes and possible gastroparesis are in this day and age of Ozempic usage, etc. How do you time the stoppage of the medication, or how do you deal with the gastroparetic aspects of the care?
So we are stopping Ozempic of every surgical procedure, even for endo cases also, we are stopping 1 week before the injection. And the tablets, even though literature says you can stop 1 day before, but we are asking them to stop like 3 days before. And then we prefer them to be on a liquid diet at least for 2 days. Coming to our OB patients, I think they need to stop it, but we can manage their diabetes with other modalities, checking their sugars constantly. If they're on other insulin doses, we can use that. But we prefer Ozempic to be stopped 1 week before, if possible. If not, the patient is going to get a general anesthesia with a rapid sequence induction in intubation. And we are also checking the gastric content with the ultrasound before the procedures and see if the patient has how much volume in there. That helps us to do a rapid sequence induction. But we are asking patients to stop like 1 week before. If they can't, then we'll go with the general anesthesia. And that if they can stop, we can do the titration of the blood sugar levels with the sliding scale with insulin.
Thank you, Dr. Patel. So there concludes the session. Thank you so much for your patience. And also, as you guys know, most of them are awake in the middle of the night because they're delivering lectures from US. So we personally thank you for being awake and giving the lecture. Thank you so much, everybody. We are concluding the CME. Thank you.
Recording stopped.